All right, hi guys, a very good evening to all of you, and welcome to our today's YouTube session where we are going to discuss some very high yield MCQs in pharmacology. So let me start the session very quickly, but before that I need a quick confirmation from all of you if I'm clearly audible and visible. I need to confirm this from all of you guys in the live chat option. You guys can comment here. You guys can let me know if I'm clearly audible and visible here. The students, those who are live, please comment in the live chat option here if everything is fine, if audio and video both are fine. All right, great. So let's get started without making any further delay with all of you guys. As I said that this is going to be a high yield MCQ, and since examination is a few days away from all of you guys, I'm pretty sure all of you guys are having a little bit of panicking or anxious like situation. But rest assured that if you have read the thing, if things have passed in front of your eyes, and when you are going to sit in the examination, you will automatically be able to recall. So this is absolutely a normal response. If you are feeling a little hanky-panky, if you are feeling a little anxious, it's absolutely normal, right? Pat your back that yes, you have read it, and that is why you are having a little bit of anxiety. You see, if there is no anxiety for all of you guys, right, then what I can say that everything, you are 100% prepared for the examination. And second scenario, if you have no anxiety, or let's say you are not anxious about the examination, then I would say that you have not read anything. So these are the only two scenarios that we can assume if there is no anxiety right now. If there is anxiety, that's a very normal response. Saying that, we can start already, and the very first question which I would like to discuss with all of you guys is this. Now all this question, it has been prepared according to next pattern, because here we talk about LN next, right? In LN next we are talking about the next pattern, and this is the upcoming thing, that even the simplest of the question according to the guideline, it should be in a form of clinical case, right? So this is a very simple question, and I would like to see your responses here in the comment section, that there is a patient was given injectable drug because of its poor oral bioavailability. The bioavailability of a drug, it is dependent on which of the following factor? Okay, volume of distribution, first pass metabolism, excretion and clearance. So we'll be little fast here, no, because we don't have much time to discuss lot of discussion, and so more number of question, more number of topic coverage is at the right is more required at this hour of time. Yeah. Okay, so I think I'm getting answers already. Yes, Dr. Sonali, we have started already. All right. So all of you, Dr. Sonali, also you can also reply. Most of you are replying. Okay, the correct answer is going to be first pass metabolism. Now there is two questions that is very frequently being asked, that what is the first pass metabolism? Let's say if this is the drug that is given via the oral route, the amount of drug that is going to reach, from the site of administration, till the systemic circulation, this area that we are having, we are going to talk this one as absorption. And in absorption, two important questions that is very frequently asked. One thing will be your first pass metabolism, other one will be your bioavailability. Now can you guys tell me what is the first pass metabolism? Again, whenever we give the drug orally, the drug will be undergoing first pass hepatic metabolism before it reaches to the circulation. The amount of drug that is reaching the circulation, we call it as a bioavailability, or the percentage of the drug reaches the circulation in the unchanged form, we are going to call it as a bioavailability. Now one very important thing, that bioavailability, guys, it is always and always going to be inversely proportional to first pass metabolism. Bioavailability is inversely proportional. Now most of the time examiner gives option, and option will be bioavailability is directly proportional to first pass metabolism. Please remember, no, it's not, right? If there is high first pass metabolism, bioavailability will be lesser. If there is a low first pass metabolism, bioavailability will be higher. Okay. So this is going to be an inversely proportional. Always remember that whenever there is a high first pass metabolism, we will not use the drug via the oral route. We prefer not to use, right? Other stuffs like volume of distribution and all, this will be discussed here. After the drug has reached to the circulation, then the drug is going to reach to the different tissues, different organ. Here only we are going to talk about the distribution or the volume of distribution. So making it very short, that do remember that bioavailability, it is dependent on the first pass metabolism. What are the other factor that can decide the bioavailability? What are the other factor? Other factor that we are having that can decide the bioavailability will be lipid solubility of the drug. the molecular size of the drug. If the size of the drug, I would say lipid solubility, size of the drug. If the size is smaller, bioavailability will be better. For larger molecules, it will be lesser. Okay. Now, saying that, we can go ahead and we can talk about the very next oriented another question, that is this one. There were 3 inotropic drugs that were tested for the heart failure. Now, this is a very simple image. You must have seen this image already in discussing your efficacy and potency, but again it has been changed in the form of it has been changed in the form of next pattern MCQ. So, go ahead and tell me what would be the possible answer. All the 3 graphs are representing one drug, right? So, drug A shows maximal inotropic support. Let me just show you this graph. I'll just zoom it in a bit and I'll show you the graph here for all of you guys, that down here on the x-axis we are having the log dose, on the x-axis we are having the log dose, and on the y-axis we are having this increase in the cardiac output. Increase in the cardiac output is there on the y-axis. Alright, these are the 3 outcome: drug A, drug B, drug C. What do you think is the possible answer here? Okay, drug A shows maximum inotropic support, B shows better inotropic than C, C and B has a comparable inotropic support or inotropic action. C is least inotropic but most potent. Look at the type of question that we have here, and this this type of question you can expect in your examination. Go ahead, all of you please try. So, I am getting mixed responses here. Some of you are telling C, others are also in favor of B, I believe. Okay, great. Moving forward, see, most of you are telling that C and B have comparable inotropic action. That is absolutely a correct answer. Now, whenever it comes to option number A, drug A shows maximum inotropic action. What is inotropic action he is representing? In this image, remember the inotropic action that we have is the maximal outcome. It is representing the maximum outcome. That means it is actually talking about the efficacy of the drug. And what have I told you in the classes, that whenever you listen to the term efficacy, think about the Eiffel Tower. And why do we know that Eiffel Tower is famous? Why is Eiffel Tower very, very famous? Because of the height, right? The bigger the height, that will be more efficacious. And second thing that I told you, what does this log dose represent? Right? On the x-axis, it is representing the potency here, right? Potency here. So, as you are moving from left to right, the potency is decreasing. Okay. So, the log dose is actually talking about the potency. It is actually talking about the potency. Do remember that? Okay. Now, if we have this information already, then I'll just quickly see. This was the image that we have seen. I think the image is quite similar to this that I'm going to draw for all of you guys. 2 drugs is having almost similar effect and 1 drug is having little lesser effect here. I think this is what we have seen. This is the type of image that we have seen. We are having drug A, drug B, and we are having drug number C. These are the 3 drugs that we have seen. Okay. Can you tell me, if you have to find out the potency of the drug, which one will be most potent, which one will be most efficacious? Potency is going to be again A followed by B followed by C. It's very, very simple. Everyone knows that, right? Potency is from left to right. This is the log dose and this is the response, or I would say the effect. Okay. Then next thing that you should know is the efficacy. Now, they have already asked this question. They are not worried about this question and they are not going to ask as well. This is what I feel, because efficacy B is going to be equal to C and least efficacious will be A. They have asked this question. There is very little chance that they are going to ask this question. Okay, then you might be wondering, फिर क्या है आपके according to me, what do you think the question that can be asked? Yes, according to me, the question that can be asked, that this potency will be affected by which factor? Which factor can affect the potency? Do remember, this can be affected by a competitive inhibitor. So when there is a competitive inhibitor with already existing drug, we will be needing a higher dose. We will be needing a higher dose. If there is a competition, let's say you are after, let's say you have a crush, right? You have a crush and you are trying to date her, but you have another friend who is also trying to date her. Now there is a competition. If you want to make sure that you date your crush first, then you have to increase the power of your love, right? You have to spend lot of money, and in that case scenario, what will happen? Potency, paisa khatam hoga, right? Just a way to remember. Now wherever we talk about potency, this can be affected by competitive inhibitor, and whenever we give competitive inhibitor, what will happen? What will happen to the potency? It will decrease the potency. Please remember, it will decrease the potency. Question number 1. Okay, then what could be the possible question number 2? What will happen to the size of the graph? Where will graph go? Up, down, left, right. So graph will be shifted more towards the right side. Done? Done? Okay, so you can expect this kind of question, right? A competitive inhibitor was given, and what would be the possible outcome? Moving forward, what is the factor that can affect the efficacy? So remember, they can get affected by a non-competitive inhibitor. And what will happen if non-competitive inhibitor is given? Do remember, they are going to decrease the efficacy. We have discussed this many times in our previous classes, in our previous sessions, right? And what will happen to the graph? Where will the graph go? Graph will be shifted more towards the downside, नीचे आ जाएगा. तो how will you remember? In a non-competitive inhibitor, graph नीचे आ जाएगा. In a competitive inhibitor, graph will be moving more towards the right side. Okay. In fact, in 2021, there was a question on the same where they show the image. So let me just show you this image. And you can expect this kind of question as well in your examination. So in a competitive inhibitor, you will be getting this kind of image where two drugs will be showing almost similar outcome. Two drugs must be showing almost similar outcome, but the effect will be right more, I mean there will be difference in the potency. So what do we see here? That the potency has decreased, graph has shifted more towards the right side. Okay. Now in a non-competitive inhibitor, I can just show you a representative image so that you can just keep in mind. Okay. So here we have, there is one drug that is going to show one response, and in a non-competitive inhibitor, it will never achieve the 100%. So it will be somewhere down here only. वो नीचे ही रह जाएगा. It will be staying down here. So we can say this is a case of non-competitive inhibitor. Okay, so you can see this kind of question as well. Apart from that, I will be showing you one more graph that will be ultra important for all of you guys. Okay, so I hope all of you guys have got here that drug C and B has comparable inotropic effect. Yes, B and C are having equal efficacy, so they are going to have a comparable outcome. Okay, C is least potent, C is least inotropic but most potent. Do you think it is least inotropic? Inotropic here is efficacy. C is right, it is having high efficacy. B and C are having equi-efficacious. The term that we use here is equi-efficacious. So C and B have a comparable inotropic action. Sorry, C is having least inotropic. This is a wrong statement. B and C have comparable inotropic. That is the correct answer. Okay, and it's also not most potent, it is the least potent. No, it is, the graph is more towards the right side. So as you move from left to right, the graph will be shifting towards the right side, and it will be decreasing the potency. Okay, moving forward, we can discuss another clinical based scenario. A 25-year-old female was on phenytoin therapy for her epileptic disorder. She is planning to conceive and seeking your advice on the possible teratogenic effect of the drug. Okay, so she is taking phenytoin actually. Which of the following defect is possibly associated or more likely associated with this drug? Yes doctor, डॉक्टर फिर कोई ले रहा है. डॉक्टर फिर कोई ले रहा है. मैंने यहाँ पे लिखा है ना, B is more potent than C. Potency order is going like this. B is more potent than C. They are, B and C are equi-efficacious, but B is more potent than C. I hope you got this point. Okay. आप लोग ना अपना सही नाम लिखा करिए. प्लीज राइट योर नेम. जैसे कि डॉक्टर रवि ने लिखा है, डॉक्टर सोनाली ने लिखा है ना, कितना बढ़िया है. फिर कोई ले रहा है ना. चलिए स्टार्ट करते हैं. बताइए इसके बारे में. टेल मी. She is planning to conceive. Which of the following is possible adverse or teratogenic effect that you can see? All the teratogenicity, guys, it is given by category. US FDA has given a teratogenicity ka category, and in this we see category A is first, followed by B, followed by C, followed by D, and last but not the least is category X. category X that we are having, guys, remember category X, it is going to be most teratogenic, and no matter what happens, we do not take or we do not give category X, right? Category X. So category X is like a real life X also, है ना? No matter what kind of benefit he or she offers, never go there, है ना? Category X always going to be dangerous for all of you guys. X category dangerous, है ना? कटने वाला है, बच के रहो. Go ahead please. इसका बताइए. Which of the following defect is possibly associated with this drug? Aplasia cutis, hypoplasia, phalanges, tendinitis. Most of you are marking actually correct answer. That's very nice. You guys are well prepared, and I'm very happy to see hypoplasia of phalanges. Do remember the condition that we are going to see will be your fetal hydantoin syndrome. Examiner asks, okay, what will be seen in the fetal hydantoin syndrome? What are the different teratogenic effect that we can see? The first and foremost, we are going to see cleft lip and palate. So instead of giving this time fetal hydantoin syndrome, they can give you this description that a patient or a newborn baby is born with this one, right? Microcephaly, cleft lip and palate, microcephaly, okay. thin upper lip, short phalanges, and hypoplasia phalanges are also seen, short phalanges, okay. All right, so this is the correct answer here. B is the correct answer. Now the question comes that what is the answer for A? I mean, which drug can cause aplasia cutis, which drug can cause tendinitis and arthropathy, which drug can cause Epstein anomaly? The next question again, aplasia cutis can be associated with a drug known as your methimazole or carbimazole, right? Tendinitis and arthropathy has been associated with fluoroquinolone. Isn't that this question has already been asked? 2022 already this question has been asked. Epstein anomaly, it can be associated with all-time favorite drug lithium. Now during the entire session today, we are going to discuss 3 to 4 important tables, and we can expect good number of questions from those 3 to 4 important tables. One of the table that I am going to give you right now for all of you guys, a quick summarized a table for all the important teratogenic effect, right? As I told you, the teratogenicity will be seen with what? Teratogenicity will be seen with which class of drug? Mainly category X. D can also cause, but again remember category X most teratogenic, and it is always contraindicated. Never give a category X drug. Okay, now go ahead, tell me thalidomide, it will be causing what kind of problem? It can lead to a problem known as your phocomelia, warfarin leading to your fetal warfarin syndrome, also given the name as a Contradi syndrome. Phenytoin causing fetal hydantoin syndrome, which we have discussed already. What are the different constituents of this fetal hydantoin syndrome? We have discussed this already. Okay. Alright, moving forward with the next one, that is carbamazepine. They can cause multiple teratogenic effect. Common one could be neural tube defect. Methotrexate, what kind of problem methotrexate can cause? They can also lead to neural tube defect. What kind of teratogenic effect isotretinoin will cause? Anyone can tell me? Isotretinoin mediated teratogenic effect. Anyone can tell me isotretinoin teratogenic effect? This question has been asked. They are not being asked nowadays. Anyone can tell me here in the comment section? I am just waiting for yours. It can also cause lots of neurological manifestation also, right? So they can lead to your CNS defect, ocular defect, facial defect, can also lead to your neural tube defect, facial defect, and a CVS defect. It is associated with multiple defects, so we do not use them actually. Do remember that. All right. Carbimazole, methimazole, can it cause choanal atresia? Can it cause choanal atresia? It's antithyroid drug. So do remember aplasia cutis. Okay. What else it can cause? Aplasia cutis, agreed. That is scalp defect. It can lead to hypothyroidism in the baby. In the newborn baby, there can be hypothyroidism. Carbimazole as a drug, as rightly mentioned by one of the doctor here, apart from thyroid abnormality, it can lead to esophageal atresia. It can lead to esophageal atresia. It can also lead to your choanal atresia. So the question to your answer, doctor, can it cause choanal atresia? The answer to this question is yes. Aplasia cutis, also given the name as a scalp defect. Aplasia cutis का दूसरा नाम क्या होता है? Scalp defect. Dr. Knight 08, yes. ACE inhibitor, they can lead to problems like your renal dysgenesis and growth abnormality. The fetal growth abnormality can also be one of the important problem here. Diuretic, again they can lead to same problem. They can also lead to oligohydramnios. They can also lead to what? Oligohydramnios. Lithium Epstein anomaly. So these are the important, right? They are the important teratogenic effect, and from this table many times we have seen questions are being asked. You guys can revise it out and we can expect question from this table. Okay, there are some more actually. Cotrimoxazole, remember it's antibiotics, right? Cotrimoxazole is combination of trimethoprim and sulfamethoxazole. What kind of teratogenic effect it will be causing? It will be causing a teratogenic effect called yellow baby syndrome. Yellow baby syndrome. One more term that we use here is kernicterus. So excessive bilirubin in the brain. Fluoroquinolone, it can lead to tendinitis and arthropathy. This tendinitis and arthropathy, boys and girls, tendinitis and arthropathy, this one side effect that we have, they are also associated in the adult population as well. That means in you and me, if we use this drug, it can cause the problem, right? Erythromycin can lead to a teratogenic effect called your congenital hypertrophic obstructive pyloric stenosis, right? Congenital hypertrophic obstructive pyloric stenosis, newborn presented with olive shaped lump. Very, very important clinical picture. Please remember that newborn with olive shaped lump, right? Which of the following drug exposure could have caused this? Erythromycin and diethylstilbestrol. This can lead to clear cell carcinoma in clear cell vaginal carcinoma in a female child. Now another thing that you should know, that this diethylstilbestrol, if the pregnant mother is going to get exposed to this one, the male child can also get exposed, can develop testicular carcinoma in the advanced ages, not at the childbirth only, but again male can also get testicular carcinoma. Misoprostol, it will be leading to a problem known as your Mobius syndrome. Examiner asks which is the cranial nerve that is going to be defected in the Mobius syndrome. So that will be most likely cranial nerve 6 and 7. Okay, streptomycin, it is going to cause mainly ototoxicity, nephrotoxicity. COX inhibitor in the third trimester. In fact, this table I have been giving since long, and we have seen one question in 2021 NEET PG, that if a pregnant female is going to receive COX inhibitor in the third trimester in pregnancy, what could be the possible outcome? There will be premature closure of ductus arteriosus. There will be premature closure of ductus arteriosus. All right. This has been one of the question. Then quinine, I think already pre-written here. Retinopathy, some congenital deafness can be seen. Amphetamine can also lead to your hepatic calcification and arteritis, right? Not very important. Quinine and amphetamine, they are not very commonly associated with these teratogenic effect, but reports are there. But do remember about streptomycin. That's why we are not using any of the aminoglycoside. Streptomycin or any of the aminoglycoside, they can cause same kind of teratogenic effect. Now, once we have discussed yellow baby syndrome, I am pretty sure all of you guys are also know that which drug is associated with the grey baby syndrome. Grey baby syndrome is associated with which drug, guys? Chloramphenicol. It is going to get associated with your chloramphenicol. Excellent, excellent, excellent. Okay. Very nice, very nice. Dr. Reformer, Dr. Strange, and all of you guys, excellent. So this was the first table. As I said, as we proceed, this is going to be a long session. So buckle up, be ready. We'll be discussing lot of question, and we expect good number of question from these topics. In a patient of chronic liver disease with the thrombocytopenia, which of the following drug will be preferred? chronic liver disease with thrombocytopenia, filgrastim, epoetin, lusutrombopag, iron dextran. Very, very simple question, I believe. Chronic liver disease with thrombocytopenia. Go ahead, please start answering. Dr. Reformer is in favor of B. Very good. Other students, please. A. Very nice. Now I'll be increasing the difficulty level of the question slowly. ठीक है, तो अब तक तो हम लोग थोड़ा बहुत easy question. In between also I'll be keeping some easy PG question, but slowly we'll be increasing the level a bit. All right. Dr. Sonali Mehta is also in favor of A. Shifali is B. All right. All right. Thank you very much, Sonu sir. Akshay Pratap Singh is in favor of A. All right, all right. So let me just talk about this question. As I said that slowly I'll be increasing the difficulty. Let's see. First and foremost, the answer that you guys are marking is simply a silly mistake. You guys are not looking that there is a thrombocytopenia. Have you not attended the class? I used to say if there is a thrombocytopenia, so thrombopoietin agonist drug. This will be thrombopoietin agonist drug. Very simple now, thrombopoietin agonist. So what are the thrombopoietin agonists that you know? What are the thrombopoietin agonists that we know? The thrombopoietin agonists that we should know or we have discussed already are going to be yes, very good, L-trombopag. अब मुझे सोच के बताइएगा, जब शाम को आप बैठते हैं तो जो पैक बनाते हैं क्या वो इंजेक्टेबल होता है या ओरल होता है? कैसे होता है? आवा ट्रोम्बोपैग पैक की बात हो रही है, हैप्पी फेस आना चाहिए, है ना? ल्यूशू ट्रोम्बोपैग है ना? तो नाम में ही सब कुछ है, पैक बन रहा है ना? कौन सा पैक है ये? थ्रोम्बोपोइटीन वाला पैक है ना? आप वाला पैक नहीं है, फार्माकोलॉजिस्ट का अलग पैक होता है. वी लाइक थ्रोम्बोपोइटीन वाला पैक, है ना? नाउ इफ दिस थ्रोम्बोपोइटीन एगोनिस्ट इज गिवन, विच टाइप ऑफ पेशेंट विल गेट बेनिफिटेड? द वन विथ थ्रोम्बोसाइटोपेनिया, है ना? सो दिस इज ओरली इफेक्टिव. This is orally effective, and remember the name of the drug is going to be your lusutrombopag. Okay, so I saw one student was able to answer this one, Dr. Solanki, Dr. Matriot, right? Excellent. Now, why will you give even iron dextran? Iron dextran to will be giving in a patient with the severe anemia, right? Epoetin, why are we giving epoetin? Epoetin, darbopoetin, what is the purpose of epoetin? Epoetin is given for which purpose? Any idea, any guesses? If there is anemia associated with the end stage renal disease or chemo-induced anemia, anemia that is occurring due to end stage renal disease, or if there is anemia due to your chemo-induced, right? Okay, why will you give filgrastim? Look at the name. Name is having everything. Epoetin, erythropoietin agonist, right? Epoetin, right? Filgrastim. These are the granulocyte stimulator drug. Filgrastim. So it will be utilized mainly in which condition, in which type of patient? Which type of patient will be benefited here? Which type of patient will be benefited here? CKD, end stage renal disease. I have used the same thing, Dr. Strange, Sonali, yeah. Filgrastim. If there is a patient with the agranulocytosis, breast cancer, okay. Does it have any anti-cancer activity? That is a real question right now. Does it have any anti-cancer activity? It does not have any anti-cancer activity, no. If there is a patient coming to you with the neutropenia, right, this can be associated with chemo-induced neutropenia or any advanced diseases, any advanced or chronic life-threatening disease, chronic condition may be also we can see this one, or it can be drug induced, है ना? Any case of a neutropenia, congenital neutropenia is also a case. For that we can use filgrastim. So they are the granulocyte stimulant. Look at the name, granulocyte stimulant, epoetin, erythropoietin, right? Isn't that this was one of the question in the 2022 FMG examination also? No, 2023 abhi jo exam hua tha 2023, this was one of the question. And why are we giving filgrastim? What is the purpose of adding filgrastim to the therapy? What do you want to prevent? Mainly to prevent the systemic infection. to prevent the systemic infection, because again this neutropenia, if there is a neutropenia, there is an increase in the risk of systemic infection, right. So, they are the granulocyte stimulant drug. I hope it is making sense to all of you. I would like to add one more point here by the name of a drug, that is your oprelevekine. Now, everything that we are discussing in the explanation is ultra important. Please rest assured that I'll be sharing this PDF. No, ये PDF I'll share at the end of the session. You will receive. You can download it from the Telegram group of LN Next. You know, oprelevekine is the interleukin 11 agonist, right. So, these are the interleukin 11 agonist. Remember, it's not antagonist, because most of the time students will be choosing antagonist. It's not antagonist, it's interleukin 11 agonist. Again, it's available by the subcutaneous route, and we can use it for the same purpose, right. If there is any thrombocytopenia, idiopathic thrombocytopenia, we can use them. But if there is a chronic liver disease, in that case scenario, we are going to prefer the PAG wala drug, L-thrombopag, avatrombopag, and right. If there is a patient with a chronic liver disease and he is planned for some procedure, for that we can actually utilize that. All right, moving forward, I hope this much is good enough for this one. Now, increasing the difficulty level a bit once again. As I said that now I will be increasing the difficulty level, because again we have to make sure that out of 28, at least we should correct 26, and if some of you will be lucky, you can correct even 28 as well. Glucarpidase is used in toxicity of. So, now in the next 2 minutes I will be giving you your second table. So, as I said, I will be giving you 4 important table in the entire session, and we can definitely expect 4 marks from those 4 tables. Rest assured about that. Go ahead. Dr. Sidhu, a PDF I will be sharing in the Telegram group. आप इसके चैनल को you guys can subscribe to the channel of LN Next, and all the updates will be given here as well, and in the Telegram group as well we'll be sharing the PDF. Okay, go ahead. Glucarpidase is used in the toxicity of what? Glucagon, insulin, methotrexate, benzodiazepines. Okay, there is answer that is coming as A, glucagon. Method is saying C, so Dr. Solanki is also saying C, that is methotrexate. Okay, so let us reveal the answer of this question, that is going to be methotrexate. Now, isn't that whenever we try to give our patient methotrexate as a drug, along with methotrexate we always add one drug by the name of your leucovorin. Now, leucovorin, it is going to make sure that the folic acid synthesis should continue. Folic acid synthesis should continue. The other name of this one will be your folinic acid. We are not going to give folic acid, remember, we are going to use folinic acid. This is also known as leucovorin. But if there is a toxicity of the methotrexate, we are trying to prevent the adverse effect of methotrexate using leucovorin. Point to be noted, we are trying to prevent the toxicity, but we are trying to prevent the ADR like bone marrow suppression. But if there is excessive toxicity, they will be actually metabolized to inactive metabolite, and also they will be metabolized to inactive metabolite using a drug known as your glucarpidase, right. So, glucarpidase, it will be helping in the rapid inactivation, and this inactive metabolite, it will be excreted. It is going to get excreted rapidly, it will be excreted out. So, I hope all of you guys have got this. Another thing what you can say, that which of the following can be used in the methotrexate mediated ADR, which of the following drug can be used? So, leucovorin, yes. Glucarpidase, yes. We also increase the hydration of this patient. This is very, very important. Hydration of patient. Then in one of the examination, examiner asked that there is a patient on methotrexate for her let us say seropositive or seronegative rheumatoid arthritis. Which of the following investigation you will be asking on the follow up? So, minimum at least 10 to 14 days after the therapy, we should ask for LFT, highly hepatotoxic drug. So, keep an eye on the LFT, keep an eye also on the counts, right, because they also causes bone marrow suppression. Okay, so given that, we can proceed with the next question. But again, as I promised that I will be giving you the next table here. So, can you tell me that glucagon is used as an antidote in which scenario, right, or benzodiazepine, and what is insulin? I mean, insulin will be given in which scenario? if there is a diabetic ketoacidosis in a patient with the hyperkalemia, है ना, if there is any stressful situation, in that also we can use insulin. But rest of the antidotes, let's understand very quickly in the table. Okay, so we have a table here where I am going to start from iron toxicity. For the iron toxicity, we use a drug by the name of your desferrioxamine. So in the next 1 minute, we are going to make one very important table. And do you know that 2022 NEET PG gave you 5 marks from this table? Can you believe it? 5 marks this table. There is one more after this. 5 marks from this table. I am not exaggerating it. The questions are already there on YouTube. Go and check it out. Prior to examination, we conducted the session. We saw the paper. 5 question. Antidotes पे आ गया था. We were lucky actually. Okay. Desferrioxamine. It's a injectable route say, but there is a oral preparation as well. Per oram, we can use a drug known as your deferriprone. We can use a drug deferriprone, and we can also use a drug known as your deferrasirox. Okay, so these are orally effective iron chelator. Okay, copper के लिए क्या use कर सकते हैं? We can use D-penicillamine for copper. Lead के लिए what you can use for the lead, right? We can use BAL, we can even use EDTA, organophosphate carbamate. We will be using a drug or antidote of choice known as your atropine. For atropine, we can use physostigmine. For atropine, we can use physostigmine. Beta blocker, I think most of you have already answered this question. Glucagon. Benzodiazepine, what we can use? Benzodiazepine, flumazenil. Okay, digoxin, we are going to use digibind. It's one of the fab fragment that will chelate the digoxin. Any chelator agent, remember, will be classified as a chemical antagonist. Like D-penicillamine is a chemical antagonist for copper. Likewise, digibind is a chemical antagonist. It will chelate the digoxin, inactivate it and promote its excretion. For morphine, do remember the drug will be your naloxone, antidote will be naloxone. Paracetamol and acetylcysteine. Examiner also asks that what is the intermediate toxic metabolite of paracetamol? Intermediate toxic metabolite of PCM or paracetamol? The intermediate toxic metabolite of paracetamol will be your NAPQI. Okay, NAPQI. Acidic diuresis doctor will be doing in basic drug poisoning that I will be telling you subsequently. If ever there is any acidic drug poisoning, let us quickly cover this as well, because ye all time favorite hai, and I have seen nowadays it's very frequently asked in the Viva as well. So you never know if it is asked. If it is asked in the examination, just put a smile on your face and mark this very carefully. Let me just bring it down here, that if we have any acidic drug poisoning, what are we going to use? Alright, now it's fine. If there is any acidic drug poisoning, example of the acidic drug like your aspirin, right? Aspirin, barbiturates, so barbs or barbiturate that we have, right? Chlorpropamide, these are all example of acidic drug, and imipramine, trimipramine. In fact, this trimipramine was also one of the question in 2022. As I was mentioning, there were 5 questions from this table, so this was one of them. Okay, so in the acidic drug poisoning, we are going to treat this one with the forced alkaline diuresis. Forced alkaline diuresis. So you will be changing the pH of the urine, right? So in the examination, although we read this a lot, but when it comes to exam, I don't know what happens. आपको thought block होना शुरू हो जाता है. आप कुछ का कुछ मार के चले जाते हो, silly mistake कर देते हो. तो बहुत आराम से सोचिएगा. Look very carefully. Acidic drug है, and you want to make sure that this drug should go out of the body. Then you will have to change the pH of the urine, the media of the urine, right? So forced alkaline diuresis will be done using sodium bicarbonate. You can simply also use carbonic anhydrase inhibitor like acetazolamide, dorzolamide, you can also use. Okay. Next that we are having, if there is a basic drug poisoning, Basic drug poisoning, right? Like for example, what are the basic drug? Like your quinine. Quinine is an example of a basic drug. Quinine is an example of a basic drug. Okay. Amphetamine. So you can see amphetamine in your option, I mean in your question. Amphetamine, now it is very much to discuss about. Quinine, amphetamine, atropine. Now the good news is that we have antidote for atropine. All these drugs that is coming under the basic, they have a in their name, right? In their name. Okay. So do a very quick analysis when you read this question in the examination, and you see if it is a basic drug, you have to change the pH of the urine, and we are now going to do this one as a forced acidic diuresis. So you make sure that you are going to make the pH more acidic. Forced acidic diuresis will be done using what? Forced acidic diuresis will be done using what? Right, NH4Cl. Isn't that you guys are very awesome? Ammonium chloride. Can we also use vitamin C or simple ascorbic acid? The answer is yes, right? So we can use this one as well. So we see that there are questions that are going to be asked from this one, and as I said, you will be receiving the PDF very soon. As the class ends, you will be receiving the PDF. A couple of more antidotes, and I am definite sure that you are going to get 1 marks from this table. लिख लो अभी कहीं साइड में that सर ने बोला 1 नंबर मुझे मिलेगा. Case based scenario will be there. Go ahead. Heparin. What are you going to give for heparin? We will be giving protamine sulfate as an antidote. I think ये तो बड़ा आसान है, right? Protamine sulfate. Warfarin we can give vitamin K1. Or if there is a bleeding or high PT-INR value more than 20, right? Or if there is a bleeding, any PT-INR value, if there is a bleeding, we can even give fresh frozen plasma. Now, which class of drug is apixaban? One more revision. What is apixaban? What is apixaban? Any ideas? It is putting a ban over 10A. Look at the name. 10A पे ban लगाने वाले drug को we call apixaban, है ना? We call apixaban. So what will you give here? Apixaban. So if you want to neutralize 10A, you will be giving Endixanet alpha. तो मैं जानबूझ के थोड़ा छोटा बड़ा लिख रहा हूँ just to make sure that you guys understand that these are 10A को neutralize करने वाले drug. They are going to neutralize 10A. Okay, moving forward, dabigatran, they are the direct thrombin antagonist. Direct thrombin antagonist, the antidote that we are going to use will be your idarucizumab. So what we discuss in the class always, idarucizumab. Idarucizumab, remember, it's a monoclonal antibody, so definitely it will begin with the injectable route. But what about dabigatran? Do you think that dabigatran is also injectable? No. Dabigatran, this is the only orally effective direct thrombin inhibitor. It is the only orally effective direct thrombin inhibitor. Okay, streptokinase. What about streptokinase? It is going to be, antidote will be epsilon aminocaproic acid. 2020 last aims before it was merged to INI-CET. This was the direct question. What is the antidote? Epsilon aminocaproic acid. Alternatively, we can also use tranexamic acid. Alternatively, we can also use tranexamic acid. What about cisplatin? Now remember, these are not antidote per se, but I have given the term toxicity and measures to reduce it. Especially for cisplatin, I am going to talk about, especially for cisplatin. How can you reduce the toxicity of cisplatin? You increase the hydration. What else you can do? What is one drug that you can use? The name of the drug that you are going to use will be your amifostine. Any drug, that is going to cause autotoxicity, and if there is another drug that is causing autotoxicity, the risk will be more. For example, cisplatin, if it is given with the aminoglycoside, the problem will be autotoxicity, okay, increased autotoxicity. Cisplatin is a highly autotoxic drug. Okay, so autotoxicity, if I am going to summarize this one as well, because I am having a very strong feeling about this autotoxic wala question. Autotoxicity with the cisplatin, it is seen. Autotoxicity will also be seen with the aminoglycoside, right? Autotoxicity can also be seen with the loop diuretics, right? Loop diuretics. So if you are going to use cisplatin with aminoglycoside or cisplatin with loop diuretics, or loop diuretic with any of them, they can increase the risk of ototoxicity. So we should avoid combining two ototoxic drugs always. Okay, so amifostine, other you can advise you can give here will be your increased hydration. All right, bleomycin, what will you use if there is a bleomycin toxicity? 2023 FMGE question, 2023 bleomycin में क्या देंगे? If there is a bleomycin toxicity, bleomycin is going to cause what? Pulmonary fibrosis, है ना, pulmonary fibrosis. Bleomycin will be causing pulmonary fibrosis. Bleomycin busulfan, and we can use a drug that is your perfenidone. Right, very good, very good. Perfenidone we can use, very good, Dr. Solanki. Cyclophosphamide causing hemorrhagic cystitis. So the patient of cyclophosphamide intake can present to you with the hematuria or bladder fibrosis. Okay, so there can be blood in the urine, hematuria or bladder fibrosis. So to reduce the toxicity, we should first infuse IV mesna. How simple is this? Doxorubicin, daunorubicin, highly cardiotoxic drug, and we are going to use what? डेक्सराजॉक्सिन. क्या बात है ना, सब लोग सही जवाब दे रहे हैं, वेरी नाइस, डेक्सराजॉक्सिन. सो डॉक्सोरुबिसिन कार्डियोटॉक्सिटी to prevent dexrazoxane, D for dexrazoxane. Then examiner asks, okay, what is dexrazoxane? It is actually a iron chelator agent. It is actually a iron chelator. What about cyanide toxicity? What you can use in cyanide toxicity? Any ideas? Cyanide toxicity. We can use hydroxycobalamin. Right, this will be chelating cyanide and they will be forming cyanocobalamin that will be promoting in the excretion. Remember this one. Okay, hydroxycobalamin. Okay, so whenever there is cyanotoxicity, we can use the antidote as a hydroxycobalamin. All right. So again, we are done with our second table, and right here on this side, on the right hand side, I have given you few very important data. Please don't mess this up in the examination. You will definitely expect question on this one. Okay. All right. थोड़ा डिफिकल्टी लेवल को और बढ़ाते हैं, एंड देन इसके बाद नीचे लेकर आएंगे. True about the receptor present and its action in the eye. It's not very difficult but highly conceptual. Autonomic nervous system भी रिवाइज करना है. मैं बोला हूँ मैं 2 घंटे में पूरे फार्मा के टॉपिक को एक बार ब्रशअप करके वापस आ जाऊँगा, और साथ के साथ in this I will also be giving you lot of important table and 2 of which we have already covered. You are going to receive the table at the end of the class. Go ahead. True about the receptor present and its action in the eye. लेवल को थोड़ा बढ़ाते हैं. Circular iridis muscle acting on the M1 receptor causing mydriasis. So this is the site, this is the action. Radial muscle acting on M3 receptor causing meiosis. Ciliary muscle acting on M3 receptor causing relaxation of the muscle. Ciliary epithelium has beta receptor causing aqueous secretion. Oh my God, this is disaster. Go ahead, all of you. आप लोग चुप मत रहिए. But I am very surprised. All of you guys are going right. Go ahead. बाकी लोग भी ट्राई करिए. ज़्यादा से ज़्यादा क्या होगा, गलत होगा ना, होने दो, कोई बात नहीं. Let it go wrong, but give it a try. All right. So I am getting answers that is towards D. That means it was not a very difficult one. Let us see why and how. Circular iridis muscle in the eye, guys, how many muscle do we have? Let's say for the function of the pupil, we are having circular iridis muscle. We actually don't have any muscle in the pupil. What is pupil? It is simply the diaphragm, or I would say the opening of the iris muscle. So we are having iris, the one that is circularly arranged, circular iridis muscle, and the one that is radially arranged, this is going to be a radial muscle. Circular iridis and your radial muscle. So the one that is radially arranged here, this is your radial muscle. Please pay attention. सारे senses को open करो. Open all your senses 2 minutes के लिए. प्लीज अभी के लिए है ना, बिकॉज ये एक बड़ा इंपॉर्टेंट कॉन्सेप्ट है. रेडियल मसल पे वी हैव अ अल्फा 1 रिसेप्टर. ओके, अग्रीड. देन वी आर हैविंग सर्कुलरली अरेंज्ड मसल. ओवर द सर्कुलरली अरेंज्ड मसल वी हैव M3 रिसेप्टर, एंड दिस M3 रिसेप्टर इट इज प्रेजेंट ऑन द सर्कुलर आइराइडिस. लेट मी राइट द नेम. सर्कुलर आइराइडिस, ऑल्सो गिवन द नेम एज द स्फिंक्टर पिपिले. radial muscle also given the name as the DP, that is a dilator pupillae. DP dilator pupillae, SP sphincter pupillae. I think itna to aasan hai. All right. Do you also know that on our ciliary muscle also we have the same kind of receptor, that is M3 receptor? Over ciliary muscle, for example, if this is the eye that you have, this is going to be your ciliary muscle. We are having M3 receptor here, right? We are going to see M3 receptor here. This area that is going in the, this is iris, and iris के बीच का जो area जा रहा है, this is your pupil. This is the lateral view, है ना? Lateral view that we have. All right. Now over this ciliary muscle we are having M3 receptor, and whenever there is M3 agonist is given, they are going to cause ciliary muscle spasm. I repeat, they will be causing ciliary muscle spasm. That is why whenever we give pilocarpine, a very common side effect we get to see is brow ache, frontal headache because of the ciliary muscle spasm. I think it's a very simple concept, not very difficult to understand. Yes. Now here, if circular iris muscle is having M3 receptor and I am going to give a M3 agonist like pilocarpine, definitely it is going to cause what? Meiosis, and the type of meiosis that it is going to cause will be known as your active kind of meiosis. So active meiosis, passive meiosis, all time favorite question of the examiner, right? If examiner is willing to make question little difficult, this could be one of the question, right? Pilocarpine causing active meiosis. Radial muscle pe we have alpha 1 receptor, and the drug like your phenylephrine, it could be one of the alpha 1 agonist. This alpha 1 agonist phenylephrine, they are going to cause active mydriasis. Okay, now why am I so much concerned with the active and passive word here, right? Active mydriasis, passive mydriasis, active meiosis, passive meiosis, because you can expect question like that in the examination. This will be causing your active mydriasis. I'll ask a very simple question from all my students, Reformer, Solanki, Metriot, all of you. Please tell me what will be the outcome in the pupil if I am going to block alpha 1 receptor. Think and tell me. There are two moments that are possible. Either there will be meiosis or mydriasis. So one is causing mydriasis, alpha 1 is causing mydriasis, M3 is causing meiosis. If alpha 1 is blocked, what will be the outcome? Tell me please. If alpha 1 is blocked, it's pretty simple. The sympathetic tone is gone. If the sympathetic tone is gone, the parasympathetic tone will be high, and that will be leading to what? Again meiosis. That is why any of the alpha blocker will be known as the drug that are going to cause a passive kind of meiosis. है ना? समझ गए आप लोग passive meiosis. Now example of alpha blocker can be drugs like your prazosin. Example of drug can be your phentolamine, doxazosine, phenoxybenzamine, है ना? Phenoxybenzamine. This phenoxybenzamine is also one of the alpha blocker, remember, and they can cause passive kind of meiosis. So active meiosis, passive meiosis done. M3 itself causes meiosis, and when you increase the activity by pilocarpine, that is going to cause active meiosis. If you are going to block the counter muscle, the one that was antagonizing like sympathetic wala muscle, we will be causing passive meiosis. Likewise, I can give you a very, very important drug right now, that if you block M3 receptor, what will be the outcome? Very simple. If you block M3 receptor, that is parasympathetic tone is gone. If the parasympathetic tone will be gone, what is the outcome, guys? The outcome that is going to see here, that we are going to see here, will be again mydriasis. So do remember M3 antagonist. I will deliberately write with the red ink here. M3 antagonist, name of the drug is your atropine. We have many drugs under this one: atropine, scopolamine, homatropine, cyclopentolate, है ना? Cyclopentolate, tropicamide. Tropicamide is a preferred mydriatic in pediatrics, adult, and for pediatrics we have atropine. Okay, because of they are very potent. Okay, so they are going to produce what? They are going to produce passive kind of mydriasis. Alright, so active meiosis, passive meiosis, active mydriasis, passive mydriasis can be asked. Now, how is this mydriasis different from the mydriasis caused by phenylephrine? How is this mydriasis different? Remember, they both will be causing mydriasis. How can you differentiate? Along with them, because the ciliary muscle is also having M3 receptor here, there will be cycloplegia. Okay, very nice. So now you know how to differentiate between these two. Done. इतनी बातें समझ में आ गई. I hope कि सब ठीक चल रहा है. All of you guys are able to do this one, right? All the M3 antagonists, Dr. Knight, आपके सामने आंसर है. All the M3 antagonists, atropine, scopolamine, homatropine, cyclopentolate, tropicamide, these M3 antagonists, they can cause. Reason मैंने आपको explain किया ना, I have explained you the concept that because M3 is present on the where? On the ciliary muscle. ठीक है? So I hope all of you guys are enjoying it, and the answer to this question, it is none other than ciliary epithelium pe we have beta receptor. They are going to cause aqueous secretion. That is why when we use beta blocker, one of the uses of beta blocker is also glaucoma. It will be decreasing the aqueous production. Beta blocker can decrease the aqueous production. There are two mechanisms. One of the mechanism could be this one possibly. All right. This is the word that they have used, है ना? Now circular iris muscle M1 receptor. Circular iris, we have M3 receptor. It is not going to cause mydriasis. It is going to cause meiosis, है ना? Yes, we can use a timolol. आपके टिमटिम आते हुए आँखों के लिए timolol, है ना? Now this timolol, it will be considered the drug of choice for open angle glaucoma, especially if the term is used India. Now why am I using this term India? Because your textbook in India has been has written this one, है ना? But if they have not mentioned the name of the country, drug of choice, best drug, most powerful drug for the glaucoma, it is none other than your PGF2 alpha analog latanoprost. Okay, but another question that is being repeatedly asked in the AIIMS is a patient with the bronchial asthma. A patient with the bronchial asthma, remember, for that we can use betaxolol. So please remember that there are also going to be drug of choice for open angle glaucoma in India, especially in patients with the history of bronchial asthma. Okay, so if there is history of bronchial asthma, we are going to use betaxolol. All right, so I think we are done here. Radial muscle पे guys, radial muscle पे we have alpha 1. I think अब आपको समझ में आ गया. ये concept should stay with you for lifelong. Active meiosis, passive meiosis, है ना? Pilocarpine is a meiotic agent. Active meiosis, it is going to cause active meiosis, है ना? It will be causing meiosis. All right, moving on to the next one. Which of the following drug can act by increasing the adenylate cyclase activity? Again, थोड़ा सा general pharma भी डालेंगे, because if you want to make a very tasty dish of entire pharmacology, a pinch of salt, a pinch of spices, a pinch of different kind of herbs and shrubs we should put, right? So general pharma के बिना paper कैसे complete होगा? We cannot. So please tell me, adenylate cyclase activity increasing, or which of the following drug will act by adenylate cyclase? So I'll give you a hint if you want. I am such a good examiner, I can give you hint in the examination as well. Think about G protein coupled receptor, think about GS, GI, GQ, and you will have your answer. Which of the following drug? Tiprolisant, telmisartan, temazepam, prucalopride. Now, if you see very carefully, some of the questions are exactly framed in the fashion which examiner likes. For example, what do you mean by examiner likes? They like asking drug with the similar sounding name or with the similar alphabet. Tipro, telmi, temazepam, है ना? There can be many other drug. Go ahead please. Answer to this question. Which is acting by adenylate cyclase? थोड़ा सा लेवल को बढ़ाया मैंने, हल्का सा अभी गियर अप ले रहे हैं. वी आर जस्ट चार्जिंग अप, वी हैवंट स्टार्टेड इवन, है ना? हम लोग बस अभी चार्ज हो रहे हैं, ये लंबा चलने वाला है. बी रेडी फॉर दिस. Adenylate cyclase. Now what do you mean by adenylate cyclase? Do you know that whenever our receptor, let's say there is one receptor, the receptor is mediated with the action of the receptor is mediated by a certain enzymes, and one of which will be your adenylate cyclase. adenylyl cyclase, and adenylyl cyclase I will be telling you subsequently. Do remember, this adenylyl cyclase activity is activated by your GS. So let's say there is a receptor called beta 1, beta 2, or any receptor that is mediated by GS. They are going to increase the activity of adenylyl cyclase, and adenylyl cyclase in turn is going to cause breakdown of ATP. They are going to cause breakdown of ATP into cyclic AMP. Cyclic AMP is going to act as a secondary messenger, right? Not only that, they will be recruiting more calcium. They are going to increase the permeability of the calcium channel. Okay, now if we already know that adenylyl cyclase activity is done by GS, because no other receptor here in G protein coupled receptor, GI is going to inhibit or decrease the adenylyl cyclase activity. GQ is going to act via IP3 and DAG pathway. The only one that is increasing adenylyl cyclase activity will be GS. An example of receptor that is going to act via GS, any of my previous student can tell me that we used to discuss about a Badshah BDSH. These are the important one that you should know. All the beta receptor, that is beta 1, beta 2, beta 3, dopamine 1 receptor. S is serotonin, so we are going to talk about serotonin ka 5-HT4 receptor and histamine ka preferably H2. Now, do you know a drug that is acting on H2? So, if we block H2 activity, right, H2 blocker, a drug by the name of, let's say, ranitidine. Ranitidine could be a drug that is a H2 blocker, all right. 5-HT4, it's acting via which one? 5-HT4, it's actually mediated via GS also, right. So, again the name of the drug here is going to be prucalopride. Now, prucalopride deliberately I have written here so that at least you revise right now and you get to know that prucalopride is also one of the drug under 5-HT4 agonists in addition to cisapride, mosapride, ticagrelor. We are not using cisapride, mosapride, ticagrelor because of the cardiotoxic events. Prucalopride is the one that can be utilized, and they are actually going to increase the intestinal motility. This prucalopride, they are intestinal prokinetic drug. They are going to increase the intestinal motility. Dopamine 1, which drug is going to act via dopamine 1? There are many drugs, right? The name of the drug could be phenol-dopam. Okay. At the beta receptor, we have many drugs like epinephrine can work, dobutamine can work. So, all of you guys are aware about that. Moving forward to this one, tiprolisant. Why tiprolisant is not the answer? Tiprolisant, guys, it is one of the H3 receptor inverse agonist. H3 receptor inverse agonist, and the action of H3 is mediated via GI. Okay, action of H3 mediated via GI. Telmisartan, it is one of the angiotensin receptor blocker. They are the sartans, they are angiotensin receptor blocker, and all the AT1 receptor, angiotensin 1 receptor, their action is mediated by GQ, IP3 DAG pathway. Temazepam, what is temazepam? It is one of the benzodiazepine. They are going to act via ion channel receptor, right? GABA mediated ion channel receptor through काम करेंगे. Prucalopride is the only one that is going to act via. It is a 5-HT4 agonist, and they are known as a prokinetic drug. They are going to increase the intestinal motility. They are the prokinetic drug. What is the use of prucalopride, guys? Any ideas, any guesses, wild guesses please? What is the use? Prucalopride का use बता दीजिए. Possible use of prucalopride. They can be used in constipation dominant irritable bowel syndrome. Constipation dominant irritable bowel syndrome, diabetic mellitus patient with the gastroparesis. So, diabetic gastroparesis may also we can use. Constipation dominant irritable bowel syndrome, diabetic gastroparesis, opioid induced constipation. As a matter of fact, any constipation we can use, right? Opioid induced constipation also is one of the indication of prucalopride, right? Prucalopride, don't forget prucalopride, very very important. Okay, now going to the next one, the correct answer for this one is prucalopride. थोड़ा सा level को मैंने up किया था, but most of you have got this already. Okay, an asthmatic patient was well controlled on salbutamol therapy. This is going to really test your general pharma knowledge. Presented with the history of migraine, he was started on propranolol for prophylaxis of migraine. Later, the patient complained that his asthma attack is precipitated. His asthma attack is precipitated, possibly due to propranolol. This type of antagonistic activity is what? pharmacokinetic, pharmacological, chemical antagonist, physiological antagonist. Go ahead please, all of you. Rest assured, you are going to have a very fruitful session, you are going to have a very interactive session here, and by the end of the session you will realize that okay, you have covered most of the important areas in pharmacology that are going to be very potential site for MCQ as well. So again, tables are coming, lot of tables are coming, lot of boxes are on its way, a couple of images are also in its way. One image that I have already discussed, a couple of more I will be discussing. Okay, most of you are telling B. Other students also please try marking. Okay. Pharmacological antagonist. Now what is salbutamol guys? Which class of drug is salbutamol? Salbutamol is a beta 2 drug. It's a beta 2 agonist. What about propranolol guys? Which class of drug is propranolol? It's a beta blocker. Now, don't you think that these two drugs are going to act at the same site? One is acting as a beta, one is acting as a beta agonist, other one is acting as a beta antagonist. Because of this reason, the basic understanding about the type of antagonist that we have, one is known as your pharmacological antagonist. Please do understand and you will not forget ever. Pharmacological antagonist that we have, where we have two agents. Pharmacological antagonist, okay, where we are going to talk about two agents. One drug is this one and we are having one more drug, right. Two agents are going to compete for the same site. So, let us say there is only one crush in your class and there are two friends that are going to be after her. Of course, there is gonna be a competition between the both of you. Okay. So, in a pharma class there is always a competition. So, pharmacological antagonists, they are going to compete for the same site, and do remember it is also known as your competitive antagonist or competitive inhibitor. Competitive inhibitor. So, two agonists acting at the same site but producing opposite outcome, producing opposite action, right. So, this is the basic definition that you should know. Producing opposite outcome. Now, let us understand this in a much better way. I will use the name of the drugs. Let us say this drug that we are having, first drug is going to be your adrenaline and the name of the receptor is beta receptor. The second drug that we are having, let us say its name is propranolol, because this was the question. So, I am going to use what is propranolol, it is a beta blocker, what is adrenaline, it is a beta agonist. That means they both have high affinity for the same site, they both are having high affinity for the same site. Therefore, when both of them are given together, if adrenaline binds, they will be increasing the heart rate. If propranolol binds, they are going to decrease the heart rate. So, that is why I said two agents competing for the same site but having opposite action, but this kind of competition is not there in physio class. It is very quiet kind of class. So, why it is that, why physio guys does not have this kind of antagonistic activity? Just a way to remember, physiological antagonist. In the physio class, do you know that there is gonna be two agents and both of them will be after two different areas. Like let us say that we have someone by the name of Akshay Pratap Singh, right, and Akshay Pratap Singh के class में let us say there is someone like his crush. We are taking the example of a crush, so वहीं से देख लेते हैं. Akshay Pratap Singh is after let us say someone by the name of Akshita, right, and there is one more by the name of let us say there is one more reformer, right, reformer is after another one and he has no competition with Akshay. Why? Because reformer likes boys. Just a way to remember, समझ लीजिए example के लिए. Let's say reformer likes boys but Akshay, right, is after Akshita. Now, do you think Akshay का कोई competition है यहाँ पे? We have one. He will always and always make a bond with the receptor. it will never go and interfere with the girl's business, right? It will never go. The second drug, this is drug number 1, this is drug number 2. Drug number 2 will never go and bind with receptor number 1. It will always and always be interested towards its own kind. वो अपने जैसे लोगों को प्यार करता है, बोलता है आदमी हूँ, आदमी से प्यार करता हूँ, है ना. सो ड्रग नंबर 1 विल बी बाइंडिंग विद द रिसेप्टर नंबर 1. वो कभी भी रिसेप्टर 2 के पीछे नहीं जाएगा, बोलेगा भाई मेरा तुमसे कोई रिश्ता नहीं है, आई हैव नो रिलेशन विथ यू, स्टे अवे फ्रॉम मी. ड्रग नंबर 2 अगेन, है ना, वो कभी भी रिसेप्टर नंबर 1 के पास नहीं आएगा, बोलेगा नहीं, आई लाइक माई ओन काइंड, मेरा टेस्ट अलग है भाई, तू अलग जा, है ना. सो हियर लेट्स से दैट दिस इज अगेन अ नेम ऑफ द ड्रग इज एड्रेनालिन एंड द नेम ऑफ द कंपाउंड हियर दैट आई एम गोइंग टू टॉक हियर, लेट्स से इज हिस्टामिन. Now histamine will be interacting with someone by the name of H1 receptor, and adrenaline that we have, it is going to act at the beta receptor. Now can you tell me, if adrenaline is going to act on the beta receptor, what will be the outcome? It will be causing bronchodilation. Adrenaline causing bronchodilation. देखिए कोई कंपटीशन नहीं, हिस्टामिन कभी नहीं जाएगा बीटा रिसेप्टर के पास, it will never go to beta receptor. Okay, histamine that we have, it is going to cause over the bronchial smooth muscle bronchoconstriction. ठीक है. बोथ ऑफ देम आर एगोनिस्ट, टू एगोनिस्ट एक्टिंग एट अ डिफरेंट साइट, टू एगोनिस्ट एक्टिंग एट अ डिफरेंट साइट एंड प्रोड्यूसिंग अपोजिट आउटकम, प्रोड्यूसिंग अपोजिट आउटकम. This is known as your physiological antagonist. So physio guys, that is why there is a lot of P's, क्योंकि सब वहाँ अपना है ना, अपना अपना सीक्रेट रखते हैं. Someone is after, right? वन क्रश, अदर वन इज आफ्टर वन क्रश. लाइक फार्मा में सब एक के पीछे रहते हैं ना, जस्ट अ वे टू रिमेंबर, है ना. ओके, नेक्स्ट वन इज अ केमिकल एंटागोनिस्ट. नाउ डू रिमेंबर केमिकल एंटागोनिस्ट दैट वी हैव, दे आर ऑल गोइंग टू बी चिलेटर्स. Chemical antagonists are all going to be chelators. Example of chemical antagonist could be D-penicillamine. Example of chemical antagonist, D-penicillamine is for the copper. It can be digibind. This could be for digoxin. Okay, agreed. Then we also have protamine sulfate is a chemical antagonist for heparin. I think I have already discussed all the important antidotes for all of you guys. And last but not the least, we are also having one more by the name of pharmacokinetic antagonist, PK antagonist. PK is pharmacokinetic antagonist. Charge up, सब लोग charge रही है ना, pharmacokinetic. This is going to stay for some more time, है ना. Pharmacokinetic antagonist. This is again by increasing the metabolism, right? By increasing the metabolism, possibly enzyme inducers. तो अगर मैं बोलूँ कि लेट्स से देयर इज अ फीमेल हु इज ट्राइंग टू क्रिएट अ स्पेसिंग बिटवीन हर प्रेगनेंसी एंड शी इज यूजिंग ओरल कॉन्ट्रासेप्टिव पिल एंड लेटर शी कॉन्ट्रैक्टेड ट्यूबरकुलोसिस और उनको स्टार्ट किया गया ऑन एंटी ट्यूबरकुलर ड्रग बाय द नेम ऑफ रिफैम्पिसिन. वी ऑल नो राइट दैट रिफैम्पिसिन इज अ पोटेंट एंजाइम इंड्यूसर एंड दे कैन एंड अप कॉजिंग अ प्रॉब्लम दैट इज कॉन्ट्रासेप्टिव फेलियर. ओके, तो ऐसे पेशेंट को क्या एडवाइस करोगे? What will you advise to these kind of patient? That they'll have to use an alternative modality of, you know, they are going to use an alternative modality of contraception, है ना. Cool, all done, all done. ठीक है. So यहाँ पे two agents are competing for the same side. Which side? Beta receptor. Therefore, this will be a case of pharmacological antagonist. How many of you have got this concept? How many of you have got this one? Please go ahead and tell me. How many of you have got this concept of different types of antagonists? और आपके एग्जाम में क्वेश्चन में देयर विल बी नेम ऑफ अ ड्रग, ड्रग का नाम देकर के पूछेगा व्हाट टाइप ऑफ एंटागोनिस्टिक एक्टिविटी सीन हियर. प्लीज गिव मी अ क्विक थम्स इफ यू गाइस हैव गॉट दिस, है ना. फटाफट फटाफट, इफ यू हैव गॉट दिस प्लीज गिव मी अ क्विक थम्स. कोई डाउट तो नहीं है? अगर आपको आ गया तो मैं इस पे क्विक एक एक्सरसाइज करूंगा. ओके, लेट अस सी हाउ मेनी ऑफ यू हैव अंडरस्टूड दिस वन. व्हिच ऑफ द फॉलोइंग इज एन एग्जांपल ऑफ फिजियोलॉजिकल एंटागोनिस्ट? आई थिंक इसका आंसर तो मैं दे दिया हूँ. वाई एम आई इवन आस्किंग दिस वन? बट लेट्स सी इफ यू गाइस कैन मार्क इट आउट. वेरी गुड डॉक्टर अक्षय, डॉक्टर सोलंकी, डॉक्टर स्ट्रेंज. ओके, नाइट, रिफॉर्मर, ऑल ऑफ यू प्लीज गो अहेड. वी हैव ऑलरेडी डिस्कस दिस, राइट? वी हैव ऑलरेडी डिस्कस दिस वन. So adrenaline and histamine are the physiological antagonists. Can you tell me what is this one? D-penicillamine and copper, they are going to be example of chemical antagonists. What about xylitol and leukotriene? What is xylitol? What is xylitol, guys? Xylitol is a 5-lipoxygenase inhibitor. It's a 5-lipoxygenase inhibitor. What type of antagonistic activity is seen here in the zileuton वाला area में? Go ahead please. Type of antagonistic activity in the zileuton is going to be chemical? No. Zileuton is a 5-LOX inhibitor and leukotriene, it will be acting on the leukotriene receptor. So, is there any competition between leukotriene and zileuton? आपने देखा है ना ये वाला ग्राफ. Let's say there is arachidonic acid. From arachidonic acid there is gonna be, with the help of 5-lipoxygenase enzyme, there will be leukotrienes. This leukotriene formation that we have, it will be acting on different leukotrienes. It will be acting on the receptor, causing, let's say, bronchoconstriction. So, if we are going to give leukotriene, it will be causing bronchoconstriction. If we are going to give 5-lipoxygenase inhibitor by the name of zileuton, what will it cause? ल्यूकोट्राइन, मान लीजिए एक पेशेंट है, आपने उसको ल्यूकोट्राइन भी दिया और आपने उसको 5-LOX इनहिबिटर दिया. तो 2 एजेंट्स. ल्यूकोट्राइन क्या करेगा? अगेन ल्यूकोट्राइन विल बी इनहिबिटिंग द 5-LOX inhibitor will be inhibiting the bronchoconstriction, and leukotriene itself is going to cause a bronchoconstriction. एक करेगा, एक उसको अवॉइड करेगा. So they are going to compete with the action of each other. So that will be an example of pharmacological. Isoprenaline, propranolol, they both are competing the action of each other, है ना. Isoprenaline and propranolol, again isoprenaline is a beta 2 agonist and this is going to be a beta blocker. So again remember, this will be pharmacological, है ना. They are also going to be pharmacological. ठीक है, moving forward. True about this statement are all except. Which of the following is a false statement? Acidic drug, तो again थोड़ा सा easy peasy रखते हैं and then we'll go back again to the systemic pharmacology, है ना. तो बीच में थोड़ा conceptual question भी जरूरी है, otherwise we won't be able to revise that area. Acidic drug is more ionized at alkaline pH. Basic drug is more ionized at basic pH. Highly ionized drug crosses the blood-brain barrier, blood-placental barrier easily. pKa is the value at which 50% of the drug is ionized and other 50% of drug is non-ionized. Go ahead please. What do you think is the possible answer for this one? All the students, please do remember that these are concept based question only. First and foremost, you tell me that other name of lipid soluble, when we have something by the name of lipid soluble here, let's say we have a lipid soluble drug, will it cross the blood-brain barrier? Will it cross blood-brain barrier? Can I also say non-polar compound will also cross blood-brain barrier, or a non-ionized compound? So all of them, they have a similar action. Lipid soluble drug, non-polar drug, non-ionized, these are the one that is going to cross the blood-brain barrier, or they can even cross the blood-placental barrier. Okay, agreed. But here it is telling you highly ionized drug will be water soluble, they will not be crossing. So this is ruled out, it's out of scene. Okay. Other option try करिए. Try out the other option. Basic drug is more ionized at acidic pH. Basic drug you have to find out a wrong statement. No? Highly ionized drug crosses the blood-brain barrier. pKa is the value at which half of the drug is ionized and other half of drug is non-ionized. Okay, so we already know pKa. This is correct actually. Half of the drug is lipid soluble, other half of the drug is water soluble. This information we know already. Basic drug is more ionized at acidic pH. What about this statement? Basic drug will be non-ionized in the basic media. So it will be ionized in the acidic media. Acid and base, they will ionized. Acid and base will ionized. Acidic drug is more ionized as the alkaline pH again, right? So they are also the a true statement. Acidic drug will be staying in the non-ionized form in the acidic media. When the medium is same, it will be staying in the non-ionized form and absorption will be better. I repeat, if the medium is same, there will be non-ionized. So acidic drug will be ionized at the alkaline, or basic drug will be ionized at the acidic. Both statements are same only, है ना? So the only thing that is exception here is, only thing which is exception here is going to be highly ionized drug crosses blood-brain barrier. No, it is the non-ionized drug. Okay. Alright, now taking your concept again to one step above, the shown image shows plasma concentration of two drugs. So we are having two drugs here that is showing in this image. Which of the following has rapid rate of absorption? If you see very closely, then A or B, A and B that we have, they are having almost similar height. Their height is almost similar, okay, almost similar. Very simple image, but I am sure that lot of you will make a silly mistake here as well. Go ahead please. Alright, which of the following drug has rapid rate of absorption? Drug A, drug B, both have same rate, B is more than A. Okay, so most of you are marking A as an answer. That is correct. A is the correct answer for this question. Do remember, whenever we talk about rate of absorption, whenever we talk about rate, this is discussed in terms of time, right? This is discussed in terms of time. Now, whenever we are trying to give a drug, let's say you are giving a drug, then slowly the plasma concentration will increase, and after that the plasma concentration will be reaching to a maximum value, and then this plasma concentration will be coming down. A time at which plasma concentration is maximum, this is your Cmax actually, this is the point of the Cmax. A time at which the plasma concentration is maximum, we call this time as a Tmax. So this is the time Tmax for drug number A, Tmax for drug number A, and drug B that we have, it is also going to increase slowly in the body. It is also going to increase, the plasma concentration is going to increase, and they will come down. After increasing, they will come down here. So do remember, this is the Cmax of drug number B. This is Cmax of drug number A, and otherwise Cmax of drug number B, and this is going to be another Tmax of again our drug number B. So two important information that you should know, that slowly when the drug is coming to the plasma concentration, it is achieving its maximum plasma concentration, we are calling it as a Cmax. So very simple question now, which of the following is having rapid rate of absorption? How can you know it's having rapid? Because it is rapidly reaching the Cmax. कैसे पता चलेगा कि रैपिड रेट ऑफ एब्जॉर्प्शन है? क्योंकि A वाला जो है वो जल्दी Cmax पे आ गया. A have achieved Cmax much faster. Then we are having drug B that is going to achieve also Cmax. दोनों का Cmax में कोई difference है क्या? There is no difference in the Cmax. Both of them are going to achieve the same kind of Cmax. But again B का थोड़ा slow है. इसका rate of absorption will be slow. How did we know B का rate of absorption slow है? We came to know with the help of our Tmax. It is achieving Tmax थोड़ा delay में. Right? So I hope all of you guys have got this one, that why A is the correct answer. Now if the examiner is going to ask you a very simple question, that which of the following is having maximum Cmax? The Cmax of A and B are going to be same. Tmax of A is more than B. Which of the following is going to stay in the body for more longer duration? Which of the following drug is going to stay in the body for more longer duration? Right? वो कैसे decide करेंगे? It will be decided on the basis of area which is covered by drug number A. So this is the area that is going to be covered by drug number A, and this is the area that we have that is going to be covered by drug number B. So for this many minutes or this many hours at this plasma concentration, the drug is going to stay. Very good, Dr. Akshay, right? So remember, if examiner is going to ask you which is having rapid absorption or rate of absorption, it will always be calculated in the terms of Tmax. Alright, then we can actually discuss these three important MCQs. That rate of absorption that we have, it will be discussed in terms of Tmax. It will be given by Tmax. Rate of absorption will be given by Tmax. Maximum concentration of the drug, I think this is very simple. This will be given by Cmax. Okay, and extent of absorption, which drug is having maximum absorption or stayed in the body for longer time? So extent of absorption will be given by your area under curve graph. Right, these three questions has been asked. Okay, in the past. Next, a pharmacodynamic property of a drug will enable the drug to be used in a low dose. Which pharmacodynamic property? Again a easy question, and then we can increase the level a bit again. Okay. A pharmacodynamic property of the drug will enable the drug to be used in a low dose, high efficacy, high affinity, high volume of distribution, high potency. Which one do you think is the correct answer? Whenever it comes to dose, we always talk about power, potency, right? So most potent drug that we have, they are mainly going to get required in the low doses. They will be required in the low doses. Potent drug will be required in the low doses. So which factor is going to decide this one? High potency, highly potent drug we need in lesser dose. Now why not others? What is high efficacy, guys? Efficacy क्या होता है? What is high efficacy? It is the maximal response regardless of the dose. Maximum response regardless of dose. Now this maximal response can be achieved by some drug in the smaller doses. Other drugs can cause the same kind of effect in the higher doses. So this does not decide, efficacy does not decides the dosing, right? Efficacy does not decide the dosing. Okay, next, that is high affinity. What is affinity, guys? What is affinity? Why it is not the correct answer? Affinity is ability of a drug, right? Affinity is ability of a drug to bind with the receptor. Ability of a drug to bind with the receptor, that is your affinity. How active they are, After binding with the receptor, do you know, some of the drugs can produce, let's say, agonistic activity. Some of the drugs can produce or present as an antagonistic activity. Some of the drugs can present as a partial agonistic activity. Some of them can also present as inverse agonistic activity. I hope you guys understand that affinity does not decide the dosing. Affinity का simple मतलब ये हुआ कि ये कितना active है to make a bond with the receptor, okay, to bind with the receptor. High volume distribution, again remember, it's not a pharmacodynamic property. Distribution is a pharmacokinetic property, and high volume distribution, always remember, when the volume of distribution is high, even if it is a pharmacokinetic property, if the volume of distribution is high, the dose that is required initially to start the therapeutic effect, dose should be kept high. And we call such dose as a loading dose. If the volume distribution is high, we need to keep a high dose, and we call such dose as a loading dose. Okay. Chalo, बहुत बढ़िया. Dr. Knight is asking, explain time dependent killing. Yes, we can discuss that as well. In upcoming session we can talk about that. However, if you want to study immediately, you can simply type this one, you will get my video. It's already there on YouTube. आप सर्च करिएगा, मैंने डाला हुआ है, आपको मिल जाएगा वीडियो, है ना. बिकॉज हमारे पास कुछ क्वेश्चंस हैं जो हम फिनिश करना चाह रहे हैं, बिकॉज आवर एम इज टू समराइज एंड रिवाइज इंपॉर्टेंट एरियाज फ्रॉम द फार्माकोलॉजी. A patient was started on antibiotic with a half-life of 12 hours. If the drug follows first-order kinetics, how much of the drug is eliminated after 2 half-life? How much of the drug is going to get eliminated after 2 half-life? Go ahead, please. MD Suhail, what does metformin do in affinity? Ayub Chap again. आपका क्वेश्चन थोड़ा क्लियर है डॉक्टर अयूब, क्लियर करिए. सोनाली, एमडी सुहेल, एलएन स्टूडेंट, फ्यूचर डॉक्टर. बिल्कुल डॉक्टर. ओके, गो अहेड प्लीज. Affinity का मतलब समझिए ना आप. Affinity is ability of the drug to bind with the receptor. So let's say you are going to give 2 drugs. One drug is, let's say, a candesartan. Let's say a hypertensive patient is coming to you and you are going to give candesartan and you are also going to give losartan, है ना. Now problem is candesartan is having high affinity with the receptor. If both the drugs are presented together, candesartan बहुत जल्दी जाके receptor से bind करेगा. कौन से receptor से? AT1 receptor से, as compared to any other drug, right? So candesartan is having high affinity. ठीक है डॉक्टर अयूब. Okay, so tell me the answer to this question, please. ड्रग इज फॉलोइंग, आप लोग बहुत टाइम ले रहे हैं, थोड़ा सा जल्दी करिए. इफ द ड्रग फॉलोज फर्स्ट ऑर्डर काइनेटिक, हाउ मच ऑफ द ड्रग विल बी एलिमिनेटेड आफ्टर 2 half lives? After 2 half life, how much of the drug will be eliminated? 33%, 50%, 75%, 93%. Do remember, if the drug is started from 100% plasma concentration, if it is following first order, it will become first half life में 50, 50, second half life में it will become 25, third half life में it will become 12.5, fourth half life में it will become 6.25, so on and so far. Simple question, if the T half life of the drug is around 12 hours, then in one day, how many such T half life will take place? In one day, 2 such T half life will take place. In one day, 2 such T half life are going to take place. So very simple, no? 1 half life, 2 half life, 3 half life, 4th half life. It will keep on happening, no? 4th half life will be giving 6.25. तो अब आसान हो गया ना. अब तो बताइए that after 2 half life how much of the drug is remaining? 25. तो कितना निकल गया? 75. बड़ा आसान है ना. बट जब मैं एग्जाम में आता है तो फिर एवरीथिंग गेट्स ब्लॉक्ड. बट आई थिंक ऑल ऑफ यू हैव गॉट दिस वन, है ना. 12 hours इज द टी हाफ लाइफ. एक दिन में ऐसे 2 हाफ लाइफ होंगे, क्योंकि एक दिन में 24 घंटा हम टोटल मानते हैं, है ना. इफ अ ड्रग फॉलो जीरो ऑर्डर काइनेटिक, इट इज इंडिपेंडेंट ऑफ व्हाट? थोड़ा सा बॉम्बार्डिंग करना पड़ेगा, अदरवाइज यू गाइस विल बी, है ना, missing some important areas. If the drug is following zero order kinetic, it is independent of. Again, very simple question, not difficult at all, but highly potential question. Half life, clearance, plasma concentration, route of drug administration. रूट ऑफ ड्रग एडमिनिस्ट्रेशन तो ऐसे ही दिया हुआ, मतलब वो डमी चॉइस है. इट्स लाइक अ डमी चॉइस. तो मैंने आपका काम को आसान कर दिया, है ना. आप क्या करना चाहते हैं? 50-50 करना चाहते हैं, फ्रेंड्स को बुलाना चाहते हैं, कॉल अ फ्रेंड, कॉल अ टीचर, क्या करना चाहते हैं? जल्दी बताइए. लाइफलाइन कोई भी ले सकते हैं आप, जो लाइफलाइन चाहे यूज कर सकते हैं. हाफ लाइफ, क्लियरेंस, प्लाज्मा कंसंट्रेशन और रूट ऑफ ड्रग एडमिनिस्ट्रेशन. अवंतिका इज टेलिंग सी. अदर स्टूडेंट्स आल्सो प्लीज टेक पार्ट. Okay, great. Now do remember, if a drug is following zero order kinetics, the amount of drug that is going to get excreted, amount of drug that is getting excreted, or I would say eliminated, it is going to get constant. It will be constant, not the percentage. Percentage, or I would say fraction, is seen in the first order. In a drug that is following zero order kinetics, amount will be constant. All right, amount is going to be constant. Okay, it will be never dependent on the plasma concentration. Let's study with the example here. From 100, let's say you're starting from 100 and you are going to take, there is a drug that is 25 milligram per hour. So 100 say it will become 75, it will become 50, it will become 25, then it will become 0. Right? So in every hour 25 milligram of the drug is going to get eliminated. However, if I am going to increase the plasma concentration to 200, it will not affect the rate of elimination. Again, it will be same. It will be 175, it will be 150, it will be 125, it will become 100. So this 200 will be coming, right, will be coming as 100 in around 4 hours compared to here when it was happening in 2 hours. So only thing that is going to change is the T half life, but the rate of the amount of the drug that is eliminated per unit time is not changing. So examiner is telling, if a drug follows zero order kinetic, it is independent of the plasma concentration. No matter what is the plasma concentration, it is going to have same. Even if you make it 400, it will be 375, 350 like that. Okay. It's for all student, Dr. Pushpendra. Concept is for all. FMG, NEET PG barely matters now. Everything is same. है ना? So I hope all of you guys have got this one. In a zero order kinetics, T half life is going to be directly proportional to plasma concentration. Higher the T half life, higher the plasma concentration, higher will be the T half life. Okay, T half life is going to be directly proportional to plasma concentration. Okay, but what is constant? That is going to be rate of elimination. Rate of elimination is going to be constant no matter what is the plasma concentration. है ना? Clearance will be inversely proportional. So everything I have summarized here for zero order kinetics. Clearance will be inversely proportional. ठीक है? Now, if I ask you what about first order, that is what my question, Dr. Ayub. What about first order? In a first order kinetics, if you are going to start from 100 and it will become 50 in the very first half life, if it is following first order, let us say 50% per hour, and it will keep on happening like this, 25, then it will become 12.5, 6.25, right. So, in the first order, no matter what is the plasma concentration, the T half remains the same and the rate of elimination, amount of drug that is eliminated will change. Kaise? If I am going to make it as a 200, in the very first half life, it will become half. In the very first half life, in the very first hour, it will become half. So, now here also, if let us say 50% per hour is the example that we are going to take, 50%. So, in 1 hour, it will become again half. Here also the T half life will remain same. So, T half life sab mein kya hoga? 1 hour. T half life here also it will be 1 hour, right. T half life will be 1 hour. But what is changing? If you pay very close attention, you will find out that this 200 is becoming 100. The amount of drug that is eliminated will be 100 milligram. The amount of drug that is eliminated here from 100 to 50 will be 50 milligram. This will keep on changing. That means higher the plasma concentration, higher is the amount of drug that is eliminated. Okay. So, in the first order kinetics, remember the rate of elimination will be directly proportional. अगर फर्स्ट की बात करेंगे, so rate of elimination is directly proportional to plasma concentration. Okay, agreed. What about the clearance? Clearance is going to be constant. And what about the T half life? It is also going to be constant. There is no change in the clearance of the constant. Constant clearance will be there, and T half life is also going to be constant. So, zero order, first order, we both have both of them we have summarized here. And do you guys know what is the drug that actually follow zero order kinetics? Can you give me name of a drug that follows zero order kinetics? Any drug name? Any drug name that follows zero order kinetics? Drugs following zero order kinetics, most of the drug will be following first order. Example of zero order kinetics. So, I used to say that getting 0 in the examination is like a war, and you put an end to this war. ये क्या हुआ? You put an end to this war. Unfractionated heparin, P for your phenytoin, here is your aspirin, all of them, right. Aspirin, ethanol, तो आपका सच्चा दोस्त ethanol ही है, बाकी सारे pseudo हैं. Ethanol you will be, you can get any time and it will always be there with you, and this is the one that is going to follow true zero order kinetics. Rest all are pseudo zero order, है ना. 2 for tolbutamide, theophylline. Tolbutamide is the phosgenic sulfonylurea, theophylline an asthmatic drug, and warfarin. So, what you should know that your heparin and warfarin, both of them are going to follow zero order kinetics. Heparin and warfarin both follow zero order kinetics, and low molecular weight heparin, example of a drug like enoxaparin, dalteparin, tinzaparin, ardaparin, they actually follow first order kinetics. So, this is one of the questions that has been repeated in the past a number of time. All of the following follow zero order kinetics except. So, you put an end to this war. Why? What kind of war? We are talking about a war in which someone is getting a 0 in the exam. So, getting 0 in an examination is like a war. So, remember like a story, and your sacha dose will be alcohol. Okay, go ahead. A patient required beta blocker therapy for his cardiac condition. All of the following are selective beta 1 blocker except. So, remember which one is not a selective beta 1 blocker. Metoprolol, cardioselective. Celiprolol is a cardioselective beta blocker with a beta 2 agonistic property, and is also going to increase the nitric oxide. Atenolol, guys, atenolol, pseudo zero order means legendary. Pseudo zero order matlab kya hua? Initially they follow first order kinetics. I can give you one example if you want. Let me talk about, there is a drug by the name of phenytoin. There is a drug by the name of phenytoin. This phenytoin as a drug, whenever it was given up to 10 to 20 microgram per ml, they actually follow first order. They actually follow first order, but when the plasma concentration was beyond 20 microgram per ml, it start following zero order. It start following zero order. right? So the toxic plasma concentration range of phenytoin is any plasma concentration beyond 20. What do we know? That whenever the plasma concentration is within the therapeutic range in the phenytoin, it's safer, we can give. Beyond 20 if it is going, we have to do the dose titration, and that dose titration is called therapeutic drug monitoring. Now did you got this one? Yes. Moving forward, a patient required beta 1 blocker therapy for his cardiac condition. All of the following are selective beta 1 except atenolol is also selective beta 1 blocker. Atenolol, remember, it's also beta 1 blocker. What we know here, this carvedilol, it's not a selective beta 1 blocker. It is a third generation beta blocker. It is not cardioselective. Third generation beta blocker, they have beta blocking activity. In addition to that, they are also having alpha 1 blocking property, right? They also have antioxidant property. They also have antioxidant property. They are the more preferred beta blocker in a chronic congestive heart failure. Chronic word I use the word I use the word chronic. Okay. After hip surgery, a patient was started on a transdermal opioid patch. Another very important question you can expect for pain relief. This route of administration is going to be intradermal, topical, enteral, parenteral. After hip surgery, patient was started on transdermal opioid patch. So transdermal opioid patch, guys, again ये थोड़ा सा आपके लिए चैलेंजिंग हो सकता है. Go ahead please, बताइए. All of you please try. Transdermal opioid. It's intradermal, it's topical, it's enteral और it's parenteral. Dr. Sonali is in favor of B. Other students also. थोड़ा जल्दी से आप लोग अपना जवाब दीजिए. So we could finish more number of questions. We have a lot of question left. Go ahead please. We are in a trial to revise pharmacology in the given time frame that we have. They are all high yield MCQs. Other students also. Intradermal is usually an injectable drug. ठीक है. Example of intradermal could be BCG vaccine. Example of intradermal could be your Montus test. Topical, the definition of topical is site of action is same as site of administration. Site of action is same as site of administration. For example, there is a patient coming to you with a conjunctivitis and you are going to give eye drop. So eye drop will be a topical. If the patient coming to you with some dermal lesion, you are going to give a cream or a lotion. This will be topical, right? So wherever you are going to apply the drug, the site of action is same as the site of administration. We call it as a topical. Enteral means the oral drugs. If a drug is going to pass via the GI route anywhere, so per orum, per rectum, they are coming under the enteral route. If it is passing anywhere from the alimentary canal, we will be calling it as a per rectal. Now coming with the parenteral, see, most of you were actually marking A or B, but you have to come till D. Examiner हमेशा ये क्वेश्चन पूछता है और आपको D तक लेकर आना है, right? Now D में क्या है हमारे पास? Parenteral, right? Transdermal patch opioid is a parenteral. Now why are you guys marking 2? B, topical. Transdermal patch. मान लीजिए transdermal patch you are going to apply on the lateral aspect of the thigh or on the upper part of the back. What will happen? There will be slow capillary absorption, and through that there will be a systemic effect, right? Systemic effect will be coming through the slow systemic absorption, right? The definition of topical is site of action is same. For example, if you are going to apply in the upper arm and you are getting a pain relief, right, from like let's say a CNS pain relief, CNS mediated pain relief, then will it be topical? आपको यहाँ पे तो प्रॉब्लम नहीं था, पेन तो let's say आपका हिप सर्जरी हुआ पैर में, है ना, हिप सर्जरी हुआ है, then remember this is not going to be topical. I hope it is making sense. Yes, thank you very much sir, Dr. Aman sir, thank you. Other students also, I hope all of you guys have got this one. All cool, ठीक है, अभी तक सब सही जा रहा है. Able to revise, able to see that the mistakes that you guys are doing in the examination usually. Yes. All right. Now these are some of the important example like buprenorphine. Buprenorphine, it's one of the transdermal patch. These are example of the transdermal patch. It's one of the opioid. Utilized in which scenario? It is one of the opioid. Utilized mainly in pain relief as a centrally mediated analgesic, opioid analgesic. Okay. Fentanyl as a drug, again they will be same. Fentanyl again, opioid analgesic. Clonidine is one of the alpha 2 agonist. So this clonidine alpha 2 agonist, it can be utilized as transdermal patch for hypertension. Rivastigmine, it's a reversible acetylcholinesterase inhibitor. It is utilized in which condition guys? Rivastigmine कहाँ पे use करेंगे? ये भी रिविजन है, कौन सा ड्रग किस क्लास का है? Rivastigmine, it will be utilized in a patient with the Alzheimer's disease. Rotigotine is a transdermal patch for Parkinson's disease. Nicotine, it is mainly utilized nicotine replacement therapy. Nicotine replacement therapy. Scopolamine, also known as hyoscine. Scopolamine कहाँ पे use करते हैं? Scopolamine, hyoscine. Motion sickness, right? Motion sickness. Other drug in the motion sickness that we can use promethazine, but promethazine is not transdermal, है ना? Promethazine is not transdermal, है ना? So testosterone, it will be utilized as a replacement therapy, or I would say if there is a deficiency. Same goes for estradiol, है ना? Like hormone replacement therapy or deficiency. Methylphenidate, it is a drug of choice in ADHD. There are transdermal patches that are available. Selegiline is one of the MAO-B inhibitor, again used for your Parkinson's disease. Oxybutynin, what is oxybutynin guys? Anyone can tell me? The last drug, which is oxybutynin. Which class of drug is oxybutynin? Solifenacin, oxybutynin, flavoxate, tolterodine, trospium. What are these? These are M3 antagonist. Oxybutynin is M3 antagonist. They are going to relax the bladder, so it will be utilized for overactive bladder. ठीक है, so important ones मैंने आपके लिए ऊपर लिख दिया है. They are going to cause relaxation of the bladder, and they are the example of the transdermal patch. Then I am just expecting that in upcoming examination they can ask you which of the following is a subcutaneous. So can you give me some example of the subcutaneous, which most of the students mark always whenever they hear the term subcutaneous. Sir, एक तो vaccine सबको याद रहता है, that is measles can be given by the subcutaneous. Which of the following can be given subcutaneous? Then next you will be marking will be your insulin. Then what else? One of the GLP-1 analog, a diabetic drug that we know, right? GLP analog. Let's say there is a exenatide. There are many actually. Exenatide, liraglutide, lixisenatide. Right. Then we are also having amylin analog. Amylin analog. They are pramlintide. Amylin analog. It is your pramlintide. What else is subcutaneously available? इतना तो मैंने बता दिया. अब आप बताओ और कुछ जानते हो जो subcutaneously we can give? Subcutaneously available. Blood forming factors, है ना? Like your epoetin, filgrastim, blood forming factor, no? Epoetin, filgrastim, oprelivecin, pegfilgrastim, all of them, right? Oprelivecin, interleukin 11 agonist, है ना? तो these are the example of subcutaneously available drug, है ना? तो यहाँ से क्वेश्चन आते रहते हैं, आ भी सकते हैं. Which of the following is subcutaneously available? Don't be disheartened when it is going to be asked. आपको पढ़ा रहा हूँ मैं, सही करके आना. A patient of generalized seizure was started on a drug which act by inhibiting voltage gated sodium channel. Among the given choices, which of the following doesn't act via this mechanism? Ethosuximide, carbamazepine, lamotrigine, phenytoin. Very, very integrated kind of question with, you can say, pediatrics, with medicine. ठीक है? By revision. My only answer, Dr. Legionary, is revision. Revision इकलौता तरीका है. ठीक है, आप लोग बताइए. अक्षय प्रताप, अल्जाइमर, ओके डन. वो पिछले क्वेश्चन का था आई गेस. अदर स्टूडेंट्स ऑल्सो बताइए, बाकी लोग. What is the answer of this one? If you will be late, we have to correctly and quickly discuss this one. Remember, these are all going to be voltage gated sodium channel blocker. What about ethosuximide? It is one of the T-type calcium channel blocker, right? It is transient type calcium channel blocker. It is also considered the drug of choice in a patient with the absence seizure. It is considered the drug of choice in a patient with the absence seizure, है ना? So do remember, it is not acting via a blocking voltage gated sodium channel. All right. Aim of the pharmacovigilance program, it is always and always going to monitor any ADR. It is going to monitor ADR to check over the cost of drug, to check over the sale, monitor the drug toxicity, monitor the potency. Potency efficacy wo to before the drug is launched, that is discussed before the drug is launched. Okay, so here to monitor the drug toxicity, pharmacovigilance program, the name itself is having pharmacovigilance, vigilance है ना, vigilance. So you are keeping keep an eye, not to check over the cost of the drug, वो उनका काम नहीं है चेक करना. विजिलेंस प्रोग्राम उनका काम नहीं है ना. देयर हेड ऑफिस इधर IPC इंडियन फार्मेकोपिया कमीशन इन गाजियाबाद है ना, जिला गाजियाबाद सबको मालूम है, दिल्ली NCR में पड़ता है ना. All right, let's see the next one. A patient on digoxin therapy developed arrhythmia. Which of the following anti-epileptic agent can be used for this patient? Pretty simple. We all know that digoxin induced arrhythmia can be treated by a drug known as your lidocaine. It can be treated by a drug known as your lidocaine. Okay, agreed. Then we can also give other agents, like for example, we can give magnesium, potassium, they can also be utilized, right? But examiner is asking which anti-epileptic drug can be used. हाँ मैंने यही तो लिखा है डॉक्टर, टी टाइप कैल्शियम चैनल ब्लॉकर. डॉक्टर दीपान्विता मोंडल, मैंने तो यही लिखा है ना बाबू बच्चे, आई हैव रिटन द सेम है ना, टी टाइप कैल्शियम चैनल ब्लॉकर. डॉक्टर मोंडल, इट्स अ कैल्शियम चैनल ब्लॉकर, ट्रांजिएंट टाइप कैल्शियम चैनल ब्लॉकर. The correct answer for this one is phenytoin. Do remember important points about phenytoin. It can also be utilized in neuropathic pain in addition to anti-epileptic drug. Of course, it's an anti-epileptic drug, तो epilepsy में तो use करेंगे ही है ना. And these are going to be contraindicated in absence seizure. All of them are MCQ, very very potential MCQ. Neuropathic pain. Recent studies are also showing that because they are having a collagenase inhibiting property, they increase the collagen deposition, they can cause gum hypertrophy, that is a side effect, and they also have improve in the wound healing, right, improved wound healing. They also have a wound healing capacity. So anti-epileptic drug having wound healing capacity, the answer is this, because of its additional collagenase inhibiting capacity, and that is why they have a side effect called gum hypertrophy. Okay, done. Next, all of the following drug decreases IOP in a glaucoma patient except mannitol. Yes, it can decrease. Carbonic anhydrase, it can decrease the production. Apraclonidine, it's a alpha 2 agonist, it can actually decrease the production. Carbonic anhydrase inhibitor, it can also decrease the production. It's a carbonic anhydrase inhibitor. Mannitol, right, mannitol, it is going to decrease the intraocular pressure by its osmotic diuretic property. Dexamethasone, guys, it's a steroid, है ना, steroid. So steroid always and always associated with ocular side effect. It can cause glaucoma. I think ये तो सबको याद होगा ना, glaucoma due to topical steroid, and other one is the cataract. So ये तो सभी को याद होगा, I'm pretty sure, due to systemic steroid, right? So the mnemonic that we always say is GTCS is a very very simple mnemonic. Glaucoma, topical, cataract due to the systemic steroid, right? ये तो सबको याद होगा. We have discussed this, also given in the textbook as well. Which of the following treatment approach is preferred for restless leg syndrome? Do remember, according to recent even 14th edition of Goodman-Gilman also, they are still preferring dopamine agonist like pramipexole. Add-on drug के फॉर्म में, add-on के फॉर्म में we can give iron therapy because they are associated with the iron deficiency anemia. We will not be using iron chelators, है ना. We can also give our patient clonazepam if the patient is coming with the intermittent symptom. So clonazepam also for relief of the intermittent symptom also we can give. Pregabalin, gabapentin is also something that can be used. Recent studies are favoring more towards pregabalin and gabapentin, that their efficacy is better than the dopamine agonist. But in fact, the 14th edition of Goodman-Gilman also they are telling the preferred agent for restless leg syndrome will be dopamine agonist like pramipexole, ropinirole. Low dose में they can be utilized. Add-on drug for restless leg syndrome could be these. A patient of Parkinsonism developed this condition. What is the most likely drug that could have caused this one? So what is this, guys? This is a case of levodo reticularis. Whenever you get to see questions like this, levodo reticularis, Think about amantadine. It is one of the NMDA antagonists. It is one of the NMDA antagonists that can cause libido reticularis, not others. Levodopa, selagelin, they are not going to cause this one. Naranjo scale is used for. तो बीच में मैं जनरल फार्मा इसलिए डाल दिया हूँ because जनरल फार्मा ANS is always going to be very very important. Carcinogenicity of a drug, mutagenicity of a drug, to assess the causality, to assess the potency, right? Naranjo scale. I'm pretty sure you must have heard about Naranjo scale, है ना? It is mainly going to assess the causality, mainly in the pharmacovigilance program, or I would say in reporting an ADR, in reporting an adverse drug reaction. In reporting an adverse drug reaction, we can use Naranjo scale to assess the causality. That is the correct answer. ठीक है? To assess the causality, not the mutagenicity. That will be mainly done before the drug is even produced, है ना? Before the drug is even started in human trial, है ना? This is the Naranjo scale that we can utilize for assessing. If the score is more than 9, that means it's a definite score, that it is the ADR is because of the shown drug. ADR is because of shown drug. So there is a scale, and there is a different score has been given 2, 0, -1 ऐसे करके, और उस पे लिखा रहेगा do you think the ADR has started after starting the drug, and after stopping the drug the ADR subsided, when it was re-challenged the ADR recurred again, ऐसे करके there are few points given, and the total score, if it is coming more than 9, you will be saying yes, this ADR is because of the, you are very definite is because of the drug. Probable, if it is coming between 5 to 8, not very very important for you to know, but you never know, the name can be asked. Possible 1 to 4, if the score is less than 1 or 0, it will be doubtful. Okay, during the COVID vaccination program, one of the health worker from your hospital developed generalized rash, wheezing and hypotension after getting vaccinated. This should immediately be reported to. Always remember, at any medical college level, especially the government setting mein, there is someone by the name of your ADR monitoring center. This ADR monitoring center has been deployed by IPC Ghaziabad, Indian Pharmacopoeia Commission Ghaziabad. So these guys at the ADR monitoring center, they are going to report to IPC Ghaziabad, and through a software, and the name of the software is your Vigiflow. Through Vigiflow, they will report all the ADR, है ना? Which of the following agent has antihistaminic agent, anti-muscarinic property, and alpha-1 blocking property? Now, whenever we hear that one drug is having all these property, histamine, acetylcholine, alpha-1, सब पे काम कर रहा है, सबको inhibit कर रहा है, you always think about tricyclic antidepressant, है ना? You always think about tricyclic antidepressant, and only drug under tricyclic antidepressant is protriptyline, one of the congener of the amitriptyline, right? So tricyclic antidepressant can cause this side effect. That is why tricyclic antidepressant, because of your histamine, antihistaminic property, they cause a side effect called sedation. Tricyclic antidepressant, because of the anticholinergic property, they can cause blurring of vision, they can cause dryness of mouth, they can lead to urine retention. All this problem can be seen. Anticholinergic problem can be seen. They can also lead to very severe constipation as well. So whenever we prescribe this one, you are going to see, Doctor Saab, right, dry mouth ho raha hai, very severe constipation ho raha hai na? Because of its alpha-1 blocking property, they can cause fall in the blood pressure. They will be causing fall in the blood pressure, and therefore they can even induce reflex tachycardia. And do remember, tricyclic antidepressant, they can also lead to a problem called metabolic acidosis, and this metabolic acidosis is an abnormality, guys, that will be leading to arrhythmia, right? Okay, so examiner asked that how will you treat TCA induced arrhythmia? For the treatment of TCA, tricyclic induced arrhythmia, how will you, what will you give? Would you like to prefer an antiarrhythmic drug, or would you like to treat this metabolic condition? The answer to this question, let's treat the underlying cause. So you are going to use the same sodium bicarbonate ka infusion. Okay, great. So बार बार आता रहेगा. All of the following are therapeutic uses of risperidone except. ये क्वेश्चन आई वॉन्ट deliberately each one of you to answer, please. All of the following are therapeutic use of risperidone except. Go ahead, please. Bipolar disorder, autistic disorder, schizophrenia, dystonia. All are therapeutic uses except. Okay. All of you are marking B, autistic. Other students also please take part. बाकी सब लोग भी पार्ट लीजिए भाई. Peaceful Indian is in favor of A, bipolar disorder. Okay. Now I'm pretty sure all of you guys have seen this is one of the PYQ. It has been asked in the past as well. And the correct answer to this question is none of the above. You guys are not correcting. I mean, none of the above that you guys have marked. Neither A, B, है ना. But one student, I think, Dr. Strange, है ना, has given the answer correctly. Dystonia. Guys, risperidone, it's a risky drug. It's the most potent atypical antipsychotics. Now, whenever we talk about atypical antipsychotics are mainly targeting D2, and atypical ones are going to target 5-HT2 receptor. So, they are going to be your 5-HT2A blocker. In addition to that, because they are highly potent, they also have a D2 blocking property. Because of this, they can lead to a side effect called your extrapyramidal symptom. They can call side effect called your extrapyramidal symptom. This extrapyramidal symptom can be dystonia. Extrapyramidal symptom can be your dystonia, akathisia. Do you know that dystonia, it is considered the earliest to occur extrapyramidal symptom? Akathisia is the most common extrapyramidal symptom, and we are going to treat akathisia with the propranolol. Another very important question. Dystonia is treated with a centrally acting anticholinergic drug by the name of benzhexol. Next that we have, it can even lead to your neuroleptic malignant syndrome, NMS. Neuroleptic malignant syndrome. Do you guys know that neuroleptic malignant syndrome का current antidote क्या है? Anyone can tell me? We were using dantrolene, we are still using now, but according to the recent guideline, the current antidote that we have is bromocriptine. This is according to Goodman-Gilman. Bromocriptine. This is the current antidote. They are telling, okay, this neuroleptic malignant syndrome is coming because of the excessive dopamine blockade. Na? So, this extrapyramidal symptom is mainly associated with this type of antipsychotic, that is your typical antipsychotics like haloperidol, droperidol. These are the drugs that are going to act as a D2 blocker, and they are mainly associated with the extrapyramidal symptom. Atypicals are not supposed to cause this one. But one atypical that is going to cause this side effect is very risky for you, and that is why I say it's very risky. It's a risperidone. It's very risky. It's a risperidone drug. Risky drug, risperidone. It can cause multiple ADRs of extrapyramidal symptom. Bromocriptine. Now, along with bromocriptine, please remember we are still using dantrolene. Dantrolene अभी भी add हो रहा है, उसको यूज करना है, बट इट इज नॉट द एंटीडोट ऑफ चॉइस. Dantrolene undoubtedly is the antidote of choice in a patient with a malignant hyperthermia. There is no doubt about it. It's the drug of choice in malignant hyperthermia. The cause of the malignant hyperthermia is different as compared to neuroleptic malignant syndrome. Neuroleptic malignant syndrome is occurring because of excessive D2 blockade. So, we have to supplement the dopamine. On the basis of that, the recent recommendation recommends bromocriptine, and they are telling, okay, for the symptomatic relief, we were getting the relief from dantrolene as well, so it is added, but bromocriptine is an antidote. I hope there is no doubt in this one. Correct answer to this one is dystonia. Dystonia is not the use. Dystonia is a ADR of risperidone. How can you use them? And it's FDA approved. Sorry, it's a FDA approved drug for bipolar disorder, autistic disorder, schizophrenia. है ना? Remember, apart from that, they are having lots of off-label uses as well. है ना? Resistant depression, है ना, is one of the uses. OCD, post-traumatic stress disorder, those are the off-label uses. I hope it is making sense. Taking the next one. A patient on reticabine therapy was started on phenytoin. What is the steps to be taken? Do you guys know that phenytoin is a very potent enzyme inducer? and because of the potent enzyme inducing capacity, there will be treatment failure. If any one of you have attended my classes before, I used to tell you a story that if you are in a relationship and if you are getting induced again and again, let's say examination is just a week from now and you are getting induction, you are getting induced daily. Chalte hain aaj, let's go today, let's do it today. The movie or the dinner I am talking about, hai na? Let's go, let's do, let's go, let's do. And if you are getting induced every time and exam is just near, what will be the outcome in the exam? What will be the outcome in the exam? The outcome is going to be failure, hai na? So if you are getting induced continuously, you are going to, hai na, see treatment failure. I would say failure. But let's say you are a very sharif kind of bacha and you are trying to make a move. Let's go. But उधर से रिप्लाई आता आज नहीं, है ना, कल बोला लेट्स गो, फॉर अ डेट आई एम टॉकिंग अबाउट, फॉर अ डिनर आई एम टॉकिंग अबाउट, है ना, बोला आज नहीं, सामने से जवाब आया आज नहीं, कल नहीं, है ना, डेली बोला आपने. अब डेली यू आर गेटिंग व्हाट, inhibited, you are nearly getting inhibited, aaj nahi kal nahi. What will happen? There will be some form of toxin, you know which toxin that I am talking about. There will be some form of toxin that is going to get deposited inside you, and what will happen one day, if she doesn't agree anymore, then after a couple of days, a couple of months, and a sudden outburst hoga, right? And again that will be causing what? That will be causing toxicity inside you. So do remember one more story here, that if there is a continuous enzyme इनहिबिशन, कंटिन्यूस एंजाइम इनहिबिशन, इसी स्टोरी को याद रखना, बिकॉज नो मैटर कैसे भी समझा लो, कुछ भी निमोनिक बता दो, एग्जाम में जाके आप लोग गलत करते हो, वो लिख के ले लो. 50% बच्चे गलत करते हैं, है ना, जिनके कॉन्सेप्ट क्लियर है वो तो सही करके आते हैं, बट अगेन निमोनिक से गलती हो जाती है. इसलिए स्टोरी इज द नेक्स्ट वे दैट आई ऑलवेज एंड ऑलवेज प्रीफर. तो बार बार इनहिबिट हो रहे हो तो याद रखना, सर ने बोला था कि अगर मैं बार बार मना करूंगा या करूंगी तो भाई टॉक्सिसिटी होने का डर, ये डर है ना, तो मना नहीं करना है ना डेट को. नेक्स्ट, पोटेंट एंजाइम इंड्यूसर, बार बार इंड्यूस भी नहीं होना है, एग्जामिनेशन नज़दीक है, फेलियर का रिस्क ज़्यादा है. फेनिटोइन इज अ पोटेंट एंजाइम इंड्यूसर. इफ इट इज गिवन विद द रेटिकाबिन, इट विल इंड्यूस इट इंक्रीज द मेटाबॉलिज्म ऑफ रेटिकाबिन एंड देयरफॉर ट्रीटमेंट फेलियर और रेटिकाबिन का इफेक्ट विल डिक्रीज. ओवरऑल एफिकेसी ऑफ रेटिकाबिन विल डिक्रीज. देयर कैन बी प्रेसिपिटेशन ऑफ सीजर. देयरफॉर डोंट रिप्लेस, इंस्टेड इंक्रीज द डोज, इंक्रीज द डोज ऑफ रेटिकाबिन. आई होप कि आपको अब ये भूलेगा नहीं. पिकॉक वाला आएगा, इनहिबिट करके जाएगा, बिल्कुल, है ना. तो ये सारी बातें ही याद रखना है एग्जाम में आपको. यू विल बी एबल टू क्रैक इट, डोंट वरी. क्वेश्चन आएगा, कर लोगे. अ पेशेंट वाज ऑन एसिटालोप्राम फॉर हिज मूड डिसऑर्डर विच इज नॉट एन ADR. डू यू नो एसिटालोप्राम इज वन ऑफ द SSRI group of drug, and all the SSRI group of drug will be causing side effect by the name of SSRI, that is serotonin syndrome, sexual dysfunction. I want to see your answer please. Sexual dysfunction, it can also lead to restlessness and insomnia. Now examiner asks, which type of sexual dysfunction? Is it going to cause impotency, hypersexuality, right? Which type of sexual dysfunction? There will be anyone, which type of sexual dysfunction? Delayed ejaculation, right? Okay. So this is going to be a happy drug for some of the patients. Why? Because this is one of the FDA approved drug for premature ejaculation. In fact, there is a drug specific SSRI by the name of dapagliflozin. ये इसी के लिए बना है, dapagliflozin, है ना, for premature ejaculation. What is dapagliflozin guys? Dapagliflozin is one of the SSRI for premature ejaculation, है ना. तो dapagliflozin आपके ejaculation को देर से, right, it will delay the ejaculation. So again it's a SSRI. Do remember this? This is the one SSRI का side effect SSRI. But anorgasmia, vomiting, insomnia can be seen. What about sialorrhea? Excessive salivation, right? Sialorrhea is associated with a drug by the name of clozapine. Okay, clozapine is a atypical antipsychotic drug. They can cause wet pillow syndrome or sialorrhea. They are having other side effect as well. Okay, now this is one very simple question in which I would like to test your memory of the central nervous system का important 5-6 drug. 6 ड्रग का मैं क्विकली रिवाइज करना चाहता हूँ. ये 6 ड्रग कहाँ बिलोंग करते हैं, ठीक है. सो सेफिनामाइड, it is going to belong to typical, atypical, antidepressant, anti-epileptic or none of the above. You guys can reply. Safinamide क्या होगा? What is safinamide? A, B, C, D option is going to be same. Do remember guys, safinamide, it is one of the MAO-B inhibitor, monoamine oxidase, MAO-B inhibitor. So they will be utilized as typical antipsychotic, atypical antipsychotic, antidepressant, antiepileptics, none. What's your answer? Safinamide, it's a MAO-B inhibitor, no? It's a MAO-B inhibitor. It is utilized in a Parkinson disease. अरे भाई मैं आंसर दे रहा हूँ, आंसर तो देख लो ऑप्शन में, स्क्रीन पे आंसर भी लिख रखा है मैंने. MAO-B inhibitor, it is utilized in the पार्किंसन डिजीज. सेलेजिलिन, रेसाजिलिन, सफिनामाइड, सेरा जैसा है ना, तो आंसर इसका होगा ई. इनमें से कोई नहीं है. रूफिनामाइड, रिसेप्टर 5, राइट. सो दिस इज गोइंग टू बी योर mGlur5 receptor inhibitor, and mGlur5 will be an anti-epileptic drug, so that is going to be your C. जिप्रासिडोन, जिप्रासिडोन है ना. अरे शिप्रा को देखा क्या? वो तो बड़ी स्लिम शॉट है. अरे शिप्रा को देखा? क्यों शिप्रा को देखना है भाई? क्योंकि वो स्लिम शॉट है. दैट मीन दिस इज वन सच ड्रग दैट इज नॉट गोइंग टू कॉज वेट गेन, इट विल बी हैविंग लेस वेट गेन. तो शिप्रा, शिप्रा है ना, शिप्रा, आई होप देयर इज नो शिप्रा इन द हाउस. शिप्रा वेट गेन नहीं कराएगी, एंड शिप्रा इज अ एटिपिकल एंटीसाइकोटिक, दैट इज गोइंग टू बी बी. Levodopa, carbidopa, it is given as a Parkinson disease therapy, right? So levodopa, carbidopa is a dopa decarboxylase inhibitor. Again, the answer for this question will be E. Remember, verbal revision is also a form of revision, okay? Carbidopa is a dopa decarboxylase inhibitor. Moclobemide that we have, it's a MAO-A inhibitor, no? Moclobemide is one of the MAO-A inhibitor. It is utilized as an antidepressant drug. It's an antidepressant drug. Sorry, rufinamide is anti-epileptic. ये CC 2 बार हो गया ना, एक मिनट, ये CC 2 बार हो गया है, इसको D करते हैं, और ये है CC 2 बार हो गया. रूफिनामाइड, इट्स एंटी एपिलेप्टिक, आई टोल्ड यू नो, सो दिस विल बी D. ओके. जुक्लोपेंथिक्सोल है ना, जुक्लोपेंथिक्सोल, इट्स वन ऑफ द टिपिकल एंटीसाइकोटिक्स. फ्लूपेंथिक्सोल, जुक्लोपेंथिक्सोल, these are penthixol drug, they are the typical antipsychotics. तो एक बार क्विकली हमने देखा CNS के इंपॉर्टेंट ड्रग्स को रिवाइज कर लिया. सो व्हाट इज मोक्लोबेमाइड? रिमेंबर, इट्स अ MAO-A inhibitor. It is utilized, MAO-A inhibitor that we have, it is going to be utilized in which person, in which type of patient, है ना, मोक्लोबेमाइड in a depression, that is antidepressant drug. All right, next. A patient is on losartan therapy. This is one of the PYQ having HbA1c high, that is 8. Which of the following should be preferred in the patient as an alternative to losartan? As an alternative to losartan, which of the following will be preferred? Telmisartan, olmesartan, propranolol, hydrochlorothiazide. Because this patient is already on a losartan and HbA1c level is high, we are going to prefer much better drug that can also have some anti-diabetic effect. And answer to this question will be mainly telmisartan, because telmisartan, it is one of the angiotensin receptor blocker. It is one of the angiotensin receptor blocker with the peroxisome proliferator activated receptor, PPAR gamma agonistic activity. This PPAR gamma, it is going to act via nuclear receptor, and they will be causing nuclear transcription, and after nuclear transcription they are going to increase the insulin sensitivity. They will be causing upregulation of certain genes that will be increasing the insulin sensitivity. So can I say this is one of the insulin sensitizer? Yes, right. Actual में in the anti-diabetic drug, a true insulin sensitizer, it is going to be pioglitazone, because they are the true PPAR gamma agonist. But here in the angiotensin receptor blocker, there is a true PPAR gamma agonistic agent that we have is telmisartan. Do remember that it will be more preferred right now for this patient. Okay. Propranolol, it can again, it's a non-selective beta blocker, and it will have no effect on reducing the glucose level. And hydrochlorothiazide, they themselves causes hyperglycemia. Hydrochlorothiazide, they themselves causes hyperglycemia. Okay. Next, a monoclonal antibody approved for familial hypercholesterolemia. So familial hypercholesterolemia के लिए we are going to use the drug that is your alirocumab. We are also having one more, evolocumab, alirocumab, inclisiran. These drugs are actually PCSK9 inhibitor. This PCSK9 is going to be proprotein convertase subtyrosine caxine type 9. What? What did I say? I said it's a PCSK9 that is going to be associated with your LDL receptor. So let us say this is your LDL receptor, this is your LDL receptor, this is your PCSK9. This PCSK9, they always and always promote the LDL receptor degradation. They promote LDL receptor degradation. PCSK9 is proprotein convertase subtilisin caxin type 9. So they are going to promote the LDL receptor ka degradation. So LDL receptor cannot be reused. Our drugs that we are going to give, that is a monoclonal antibody, alirocumab, evolocumab, and other one is your inclisiran. They are going to occupy, they are going to bind or chelate this PCSK9, and after binding with this PCSK9 they will dissociate from here. So mainly whenever we give this class of drug, alirocumab, evolocumab, inclisiran, there will be increase in the reuse of LDL receptor. Increase in the reuse of LDL receptor. Okay. Now adalimumab, can we rule out quickly, very quickly about other option like bevacizumab that we have? It is a vascular endothelial growth factor inhibitor. It is utilized in a patient with the proliferative diabetic retinopathy, also can be utilized in a patient with a colorectal carcinoma. What about the other option like infliximab? It's a infliximab, TNF alpha inhibitor. Adalimumab, golimumab, it's also one of the TNF alpha inhibitor. Okay, that can be utilized in rheumatoid arthritis, inflammatory bowel diseases. All right, so I hope कि थोड़े बहुत monoclonal antibodies भी आपने पढ़ा है ना? And this type of question has been asked in the examination. Very simple question. There is after COVID-19 outbreak, a patient lost his job and is struggling for survival. He is staying mostly alone and is developing suicidal tendency. He consulted a physician who started him on antidepressant. A psychotropic drug which inhibit the reuptake of serotonin can cause this kind of side effect. So which of the following antidepressant, simple question है, that can cause visual related side effect? Visual यही है ना? Sorry, ये है a psychotropic drug which inhibit the reuptake of serotonin causes which kind of side effect? So the again the answer will be the one that inhibit the reuptake of serotonin. Is it going to cause visual disturbances? Is it going to cause dry mouth, constipation, or is it going to cause your sexual dysfunction? I think I have told you we are going to talk about SERT inhibitor, serotonin transporter inhibitor, and the name of this drug is SSRI, and they can cause sexual dysfunction. Have I told you already this one? Yes. Which of the following antiarrhythmic drug can cause the shown side effect or the shown effect? So the arrow is the one that they are going to ask here. Arrow is the one that they are asking here, that it is caused by which of the following drug? Go ahead, please tell me. That when you look at the normal action potential duration, ठीक है? When you look at the normal action potential duration and the arrow mark, arrow one, and the one with arrow they are asking actually, the one with arrow they are asking actually. Go ahead, please. Diprocainamide. Okay, very good, very good. Other students also please take part. Now what is happening? There is a decrease in the slope of depolarization. If you see here, there is gonna be decrease in the slope of depolarization. Then definitely we have seen it is having sodium channel blocking property, because sodium influx is going to cause the depolarization. And after that we can see that there is also slowing down of the repolarization. Now the exact complete concept of this one, I am sure you guys can understand that the time is not permitting to discuss this one. It will take simply half an hour or sometime more than that. But you can know that depolarization because of sodium, when you block the sodium, depolarization will be slowed down, and the efflux of the potassium is causing the repolarization. And when we are going to give any of the potassium blocker, it can cause this problem. That means this drug is having sodium blocking property and potassium blocking property. Which drug is having sodium and potassium both blocking property? Class 1A. Class 1A will be your Queen, Prince and Dasi. So this is why I say they are A grade people. We have a quinidine, we have a procainamide, quinidine, procainamide, and we are also having a disopyramide. quinidine, procainamide, and we are also having a disopyramide. So they are the class 1 antiarrhythmic drug. They are all going to be associated with the QT prolongation, because we can see here there is actual QT prolongation. There is increase in the action potential duration, which will be corresponding to the QT interval with the ECG. Okay. So this is going to be one area. Which other drug can cause? So if you want, I can quickly summarize some of the other important areas as well. For example, if you see, there are 3 important action potential duration, and you have seen class 1A, it is decreasing the slope of depolarization, and after decreasing the slope of depolarization, there is also going to be increase in the repolarization. So the action potential duration is going to increase. What about class 1B? It will be actually decreasing the slope of depolarization. Okay, agreed. But what about class 1B ka additional activity? It is a potassium channel opener. Because of this, there will be decrease in the slope of depolarization, and there will be decrease in the action potential duration. If I tell you guys that class 1C is only a sodium channel blocker, it will be decreasing the slope of depolarization. Because it is having only action on the sodium channel, there will be no change in the repolarization. So again, the action potential duration will be unchanged. Do you know that 2022 NEET PG exactly asked this question, right? This is class 1A antiarrhythmic drug, so Queen, Prince and Dasi. This is going to be class 1B antiarrhythmic drug, lidocaine, tocainide, phenytoin, है ना? Like to phone me. The drugs here are going to be your lidocaine, tocainide, phenytoin, maxilitine. Class 1C, they are doing all the C grade वाला work, है ना? C grade वाला work in a society will be, वो होता है फ्लोर पर मॉपिंग एक्सेट्रा, ये सब सी ग्रेड वाला काम है. फ्लोर पर मॉपिंग मतलब फ्लिकेनाइड, ये सब सी ग्रेड वाला काम. दैट मीन सी ग्रेड वाले एरिथमिया के लिए यूज होते हैं. लाइक WPW सिंड्रोम, नॉट वेरी कॉमन, राइट? Propafenone, its structure is like propranolol, so they have beta blocking property. Moricizine, NK-nide, okay, this is the right class 1A, class 1B, class 1C. Now similar to this, if I want, I can just put one more information to all of your very fragile brains, and that will be and one more drug. Let's see that we are having one more action potential duration, and in this one I am going to show you a very different action. Look at this. There is action potential duration and there is no change actually. Action potential duration, that is the slope of depolarization is going to be absolutely normal. वो उसमें कोई change नहीं है. But what we saw that there is only increase in the action potential duration. There is no change in the slope of depolarization. This is going to be same actually. So let me just make sure that there should be no confusion. Slope of depolarization is absolutely usual, but only there is increase in the repolarization. This will be class 3 anti-arrhythmic drug. This will be class 3 anti-arrhythmic drug, right? Example of class 3 anti-arrhythmic drug could be amiodarone, dronadarone, okay, sotalol, ibutylite. These are the class 1 class 3 anti-arrhythmic drug. So I hope कि anti-arrhythmic drug भी एक बार quickly आपने देख लिया. And what is the important side effect of amiodarone? Pulmonary fibrosis, corneal microdeposits, and a QT prolongation. Hepatotoxicity. So given the scenario, there is slope of depolarization is also decreased and action potential is also increased. The name of the drug is going to be possibly and more likely which one? Procainamide, Queen, Prince and Dasi, A grade wale. Okay. A patient was started on venlafaxine as an antidepressant drug. Venlafaxine, remember guys, it is a SNRI group of drugs, serotonin noradrenaline reuptake inhibitor, है ना? So they are going to increase the level of serotonin and they are also going to increase the level of noradrenaline, right? Next, MAO-B inhibitor. I think I told you MAO-B मेरा बेटा शेरा के जैसा, शेरा जैसा, that is stand for selegiline, selegiline, rasagiline, selegiline, rasagiline and safinamide. Okay? तो मेरा बेटा किसके जैसा? शेरा के जैसा. किस में यूज करेंगे? In a Parkinson disease patient. All right. Okay, so a couple of more questions, then we are going to get done. A patient on long-standing anticonvulsant, there is a progressive contractility of the visual field. Long-standing anticonvulsant, progressive convulsant, that will be vigabatrin. Contractility of the visual field will be vigabatrin. It's one of the GABA transaminase inhibitor. It will be causing, tunnel vision or tubular vision. They can cause tunnel vision or tubular vision. 30-year-old patient was diagnosed with psychiatric condition due to excessive talkativeness, hyperactivity, undue shopping and decreased sleep. Hyperactive person, mostly talking about mania. Which of the following anticonvulsant is not effective in this patient? So do remember, for mania we can use multiple drugs. The drug of choice undoubtedly is going to be lithium. In addition to lithium, what else you can use? In addition to lithium, what else you can use? We can use other drugs like your atypical antipsychotics. We can use atypical antipsychotics, carbamazepine. We can also use topiramate, and we can even use valproate. So these are the drugs that can be used in mania, or can also be used in bipolar disorder, है ना? So for the bipolar disorder in the manic phase, if the examiner asks what all drugs that we can use, so lithium act well. Lithium is going to act well. So correct answer for this one is going to be phenytoin. Remember, phenytoin does not have any mood destabilizing property here, right? It's mainly anticonvulsant. It is having antiarrhythmic property, but does not it cannot be used in mania. Among the given drug, this is going to act at the melatonin receptor and is used for the insomnia. So melatonin, MT1, MT2 receptor agonist. It is going to be none other than ramelteon. है ना, ramelteon. What is melagatran? That can be one of the confusing option for all of you guys. It's a thrombin antagonist. Melagatran is one of the direct 2A inhibitor, है ना. It's a anticoagulant, है ना. It's an anticoagulant. Then there is a patient who is losing money in gambling. 38-year patient of early onset Parkinsonism. He was started on certain drug. Complaint of some atypical behavior like hypersexuality, losing money in gambling habit. Which of the following agent is known to cause the shown symptom? So he was started on some unknown drug which relatives cannot say. डॉक्टर साहब किसी दवा पे था, कुछ खा रहा था, but now he is having this very atypical kind of symptoms, है ना. So these are known as your compulsive behavior. Do you know which drug can cause development of this compulsive behavior? The drug that can cause development of this compulsive behavior is mostly going to be levodopa. And in addition to this, we also know dopamine receptor agonist. What is the dopamine receptor agonist? What is the dopamine receptor agonist? Pramipexole, ropinirole, rotigotine, है ना. Very good, very good. So ये compulsive behavior कर सकता है ना. Antisocial behavior, gambling habit, है ना. बार बार अपने आप को ready करेगा, है ना. This will go and make sure that he is always ready, looking in the mirror, है ना. So sometimes we confuse कि ये बंदा जो है ना, प्यार में है, उसके वजह से बार बार रेडी हो रहा है, बट नहीं, वो मेडिसिन है ना. Okay, when will you take the sample of lithium? So always remember that is going to be 12 hours after the last dose. For example, if the patient has taken the drug in the night, again in the morning before the next dose, you can collect the sample, 12 hours after the last dose. A dyslipidemia patient, and when will you start minimally? Minimally at least after 7 to 10 days after the therapy. You will be starting 7 to 10 days. Some textbook also say 5 to 7 days, है ना. कहीं कहीं 5 to 7 days भी लिखा हुआ है, कहीं कहीं है ना 7 to 10 भी लिखा हुआ है. तो मैं आपको पहले से ही बोल दे रहा हूँ ना. तो एटलीस्ट एक हफ्ता 10 दिन ट्रीटमेंट दे दो, then you start the therapeutic drug monitoring. Dyslipidemic patient was on statin. Which of the following is the major side effect? Statins always cause myopathy. This myopathy can simply range from, simple myopathy. It can range from simple myopathy to life-threatening condition, life-threatening rhabdomyolysis. This rhabdomyolysis, it will be especially seen if the patient is on enzyme inhibitor, especially with the enzyme inhibitor. अगर साथ में कोई enzyme inhibitor ले लिया तो that can be very very problem. Statins के साथ बहुत बड़ा problem है, myopathy as a problem, है ना. And always remember, flushing is going to be associated with your niacin. Okay. First flushing, increase in the uric acid level, they will be associated with the niacin. Which of the following anti-anginal drug can act by late sodium channel blockade? So late sodium channel blockade that we have, late sodium channel blockade, not early onset. Early onset sodium or early slow influx sodium will be IF blocker. Late will be ranolazine. है ना. Trimetazidine is a fatty acid oxidation inhibitor. Okay. So ranolazine mainly it is going to inhibit the late sodium influx. For example, let's say there is a myocyte which is undergoing ischemia. there will be opening of the late sodium channel that is going to cause influx of the sodium. This influx of the sodium, boys and girls, remember, it will be abnormal. It's not physiological. Any influx of the sodium inside is not physiological. Okay, if there is a sodium inside, it's not physiological. Therefore, if you want to get rid of this excess sodium, there will be activation of NCX. The meaning of NCX is sodium calcium exchanger. This sodium calcium exchanger, it will be causing two important things. One will be sodium will be immediately effluxed out. Okay, so we are trying to achieve a balance of sodium, and we are trying to maintain electro neutrality here. But at the same time, what will happen to the calcium? Calcium will be coming inside, because sodium calcium exchanger, they are going to exchange, so sodium is going out, calcium is coming inside. So there will be calcium overload. This calcium overload that we have, this calcium overload, it is going to cause diastolic wall stress. So during diastole, the myocyte is supposed to receive oxygen, but here it will not receive any oxygen, right? It's not going to receive the oxygen, and there will be again decrease in the supply and demand will continue. So there will be diastolic wall stress. Demand is high, supply is lesser. It is going to continue with the ischemia. So ischemia will be further worsened out. Now none of these things that is mentioned here will ever happen if the sodium channel could be blocked in the very first position. So if we block this sodium channel, our work will be done. So whenever we block late sodium channel, there will be, what will happen? There will be no influx of sodium, there is no accumulation of sodium, there is no activation of NCX, there is no calcium overload. None of the thing could be processed further, none of the thing would proceed further. Okay, so I think all of you guys have got this point here, and this is your ranolazine. Last, I can take 3 more questions that we have. We are having 3 more questions. 65-year patient presented with generalized edema, family history reveals of previous MI, occasionally breathlessness, chest x-ray suggestive of pulmonary edema, you are suspecting congestive heart failure. Okay, so diagnosis has been given already. Which of the following statement is incorrect? Now most of the questions that we have covered here, boys and girls, remember, it is totally in a pattern of next. This is how your next question would look like, and sometime a bigger clinical case can also be seen here. Okay, so which of the following statement is incorrect? So let's say there is a case of heart failure, start patient immediately on IV diuretic therapy. Yes, I think we can start. So this is correct. You have to choose an incorrect statement. Loop diuretic is ideal for reducing. Yes. Desmopressin should be started at as peripheral congestion is present. Loop diuretic is always preferred, right? It's always preferred in congestive heart failure. Okay, beta blocker should be avoided in acute condition. So beta blocker can be given in a chronic congestive heart failure, that is good, but in an acute condition they should be avoided. तो ये भी सही है. Correct answer that we have is C, desmopressin. Try to understand. Desmopressin should be started at peripheral congestion is present. Do you know what is desmopressin? Don't you think it can cause a more vasoconstriction? Yes or no? Don't you think it will be causing more vasoconstriction? Let's say if this is the V2 receptor that we have at the collecting duct. So let us talk about a V2 receptor which is present at the collecting duct. Whenever this V2 receptor is getting stimulated, there will be causing upregulation of aquaporins. Because of the upregulation of the aquaporin, there is gonna be a reabsorption of the water. The water will be taken inside. Alright, the water is going to be taken inside. Our desmopressin that we have, it is what? Vasopressin analog. So in a next scenario, if you are going to give, let's say, a desmopressin or vasopressin analog, what will happen? It will stimulate this area again. There will be more upregulation of the aquaporins, and because of the more upregulation of aquaporin, there will be more reabsorption of water. More reabsorption of water, boys and girls, will lead to what? More congestion in the body. So desmopressin that we have, or the V2 receptor agonist at the collecting duct, will it give relief from the problem, or will it cause congestion? It will cause more congestion, it will worsen the problem. Also, they are vasoconstricting in nature. So do remember, desmopressin that we have, it can be drug of choice in a patient with the central diabetes insipidus. Okay, because in diabetes insipidus the fluid is all going out, so we have to make sure the polyuria should be reduced. Okay, desmopressin, it is also having vasoconstricting property. It should not be used, it should not be utilized in a patient with the congestive heart failure. Okay, Very good, Dr. Obito. That's a very good idea. You know, in the examination, you should be very, very smart in, you know, choosing your answer, because sometimes you might not know, the correct answer, and just by using the rule of exclusion, you can actually get the answer correctly. Hai na? So, smart approach for solving the MCQ is very, very important. And I always say to all our students that solving MCQ is an art that you learn over a period of time as you solve, and this is one of the most commonly utilized art rightly mentioned by Dr. Obito. Okay, चलिए यहाँ पे अब हालचाल भी होने लगा. ओबीतो, सोनाली, चलिए अच्छी बात है. तो आई थिंक डेस्मोप्रेसिन नहीं यूज करेंगे. ओके, लास्ट क्वेश्चन. 7-year-old patient was brought with complaints of nocturnal enuresis. Serum analysis shows reduced ADH level. You are suspecting this condition to be central in origin. What will you use? Okay, so if there is a central diabetes insipidus, I told you know that desmopressin, it is the drug of choice in a patient with the central diabetes insipidus. Conivaptan, here it is considered the drug of choice in a patient with the SIADS, syndrome of inappropriate ADH secretion. Chlorthalidone that we have, which is thiazide diuretic, it is going to be drug of choice in a patient with the nephrogenic diabetes insipidus. ये लास्ट क्वेश्चन होगा हमारा. नेफ्रोजेनिक डायबिटीज इंसिपिडस. अमाइलोराइड, व्हाट अबाउट अमाइलोराइड गाइस? अमाइलोराइड क्या है? अमाइलोराइड, डू रिमेंबर, इट इज अ एपिथेलियल सोडियम चैनल ब्लॉकर. एपिथेलियल सोडियम चैनल ब्लॉकर, एंड दिस विल बी कंसिडर्ड द ड्रग ऑफ चॉइस इन अ पेशेंट विद द लिथियम इंड्यूस्ड डायबिटीज इंसिपिडस. तो देखिए इस क्वेश्चन में मैंने 4 तरह के ड्रग ऑफ चॉइसेस आपको बताए हैं और वो चारों इंपॉर्टेंट है. Amiloride is a longer acting drug. It's a drug of choice in a lithium induced diabetes insipidus. Last question, थोड़ा दमदार होना चाहिए, है ना? Okay, drug of choice for nephrogenic will be chlorthalidone. Drug of choice for central diabetes insipidus, it is going to be desmopressin. And conivaptan, conivaptan will be the drug of choice in SIADH. Conivaptan, what is conivaptan guys? It's a V2 receptor antagonist, V2 blocker. ठीक है, ये तो आसान वाले हैं डॉक्टर. सेंट्रल डायबिटीज इंसिपिडस के लिए आप यू विल बी यूजिंग है ना वैसोप्रेसिन एनालॉग. सो सेंट्रल के लिए डेस्मोप्रेसिन आपने यूज किया. नेफ्रोजेनिक के लिए क्लोरथेलिडोन, थायजाइड डायरेटिक. नेफ्रोजेनिक के लिए ये तो कॉन्सेप्ट बेसिस है, दीज आर ऑल कॉन्सेप्ट बेसिस, है ना. रटाफिकेशन से इसमें तो रटाफिकेशन करना ही नहीं है आपको, ठीक है. So this will be everything which I wanted to discuss with all of you guys in our today's session. I hope you guys have enjoyed the session, and we have discussed some very important areas here. Okay, you will be getting this slide in the Telegram group that we are having. All right, chalo. Bye bye to all of you. Bye bye to all of you. Thank you for your presence and attendance. It was a long session, but I made sure that some of the very important areas, especially from general pharma, ANS, central nervous system, cardiovascular system, renal area, has been discussed very thoroughly. Right? Chalo. A Telegram group link, it will be mentioned right now. You can see it easily after some time. अभी आपको 10 सेकंड में दिखना शुरू हो जाएगा टेलीग्राम ग्रुप. ठीक है, चलो आप सर्च करेंगे, मेरे नाम से मिल जाएगा. आई थिंक देखिए आ गया ना, मैसेज आ गया. सो यू कैन चेक इट आउट, देयर इज अ लिंक बैक देयर, यू विल चेक, यू कैन चेक इट आउट द PDF फ्रॉम देयर. चलो, बाय बाय टू ऑल ऑफ यू. बाय बाय, गुड नाइट, टेक केयर.